Good morning, everyone, and welcome to the 5th Central East Regional Education event. Our theme for today is All Shapes and Sizes Matter. Next slide. I know a few of you have had some troubles getting on today. You were linking into the actual calendar event for Teams instead of the address. But hopefully most of you are here now. As you can see from the agenda, we have some great topics to talk about today. What a great turnout so far for this virtual event. We have representatives here from our 32 sites, as well as representatives from our 13 regional cancer programs throughout Ontario. And thank you everyone for joining us today. Just a couple of housekeeping items I'd like to go over. I know it's on your screen, but I'm going to read this so as if anyone's listening on their phone that they're aware. Questions will be addressed with speakers at the end of each presentation. This event will be monitored for participation by your email address, and the recording will be available in 14 days. Certificates will be issued from Kmart only on the completion and submission of your survey form, and this will be available in the Q&A area and in a link at the end of the presentation, and only available to attendees who are present today. And as I said, this is a monitored event. The survey needs to be submitted within 1 week of the event to receive your certificate. All sessions done as a group will need a manager to send me, Glenda Russell, names and emails of who attended under their supervision to receive evaluation and certificates. So if we can go on to our welcome speaker now. Our welcome speaker today is Kathy Slevin. Kathy is the Regional Director of the Central East Regional Cancer Program and the Durham, Ontario Health Team. Kathy is an occupational therapist who holds a master's degree in healthcare administration. She has more than 25 years of health system experience in both clinical and leadership roles. Now it's my pleasure to invite Kathy to deliver our opening remarks this morning. Kathy?
Thanks so much, Glenda. And on behalf of the Central East Regional Cancer Program, I'd like to welcome you to our 5th annual OBSP Education Day. Once again, we're bringing this event to you virtually, and we're happy to welcome participants from around the province, as Glenda mentioned. It goes without saying, most of us look forward to the return of in-person events where we can connect with our colleagues under one roof. But I'm grateful that events like this allow participants who might not otherwise be able to join in person attend and participate. So I'd love to thank now the Planning Committee as well as our engaging lineup of presenters for their hard work and dedication in preparing for today's event. My sincere appreciation goes out to Glenda Russell and Dr. Shaheen and all the members of the Central East Region's Prevention and Screening team and Indigenous Cancer team for their leadership and preparation in preparing for today's event. There's been a lot of behind the scenes work going on, as I can attest, and I'm sure many of you realize it takes a lot of work and effort to put an event like this on. So as regional cancer program colleagues, we're all committed to a common goal of providing the very best cancer screening programs to ensure breast cancer is found early. And the theme of this year's event is equity. And today's lineup of speakers will highlight the need to ensure that ours is an equitable system, one in which every person has access to screening and follow-up care. Throughout the pandemic and its many ripple effects, technologists, radiologists, nurses, and all the staff that contribute to cancer screening and care have continued to demonstrate compassion, courage, resilience, and professionalism in the face of so many challenges. Your commitment to the health and well-being of the patients that you serve has never been more evident as you continue to provide safe, high-quality care for our patients. And I'd like to start today's event off with a land acknowledgement. Today, I'm joining you from Whitby, Ontario, in the Central East region. I respectfully acknowledge that the land I'm on today, and where my great-great-grandparents arrived from Ireland in the late 1800s, is the traditional territory of the 7 Williams Treaties First Nations that include Mississaugas of Scugog Island, Curve Lake, Alderville, Hiawatha, Chippewas of Georgina Island, Chippewas of Beausoleil, and Chippewas of Rama. Many of you are located in other parts of the province today, so I encourage you to take a few moments to reflect on the land you are currently on and its original peoples. We offer our gratitude to the Indigenous peoples for their care and teachings about this land and for sharing the traditional knowledge about our relationship to the earth and all living things. We're called upon to use this knowledge so that we can in turn treat all living things with honor and respect. And as we learn today and reflect on what it means to deliver equitable health services, it's important to acknowledge the impact of colonization on the health of Indigenous people of Ontario. It's also important to reflect on our own responsibility as healthcare providers to strive for equitable care and outcomes for First Nation, Inuit, Métis, and urban Indigenous peoples. In the Truth and Reconciliation Commission's 94 calls to action, the health section calls for the need to improve health outcomes for Indigenous peoples in Canada. And my own commitment to reconciliation is to work alongside Indigenous people to achieve the goal of health equity. I want to thank everyone once again for joining today, and it's going to be a great lineup, as I said, and I'll hand it back over to Glenda now to say a few more words.
Okay, so I would like to welcome everybody again. And our first presentation is our Regional Breast Imaging Lead, Dr. Rula Shaheen. Rula is a global advocate for breast screening, participating in leading national and international training sessions. Her passion for empowering women's leadership in healthcare also extends to empowering patients to be proactive in the maintenance and monitoring of their health. Please welcome Dr. Rula Shaheen.
Dr. Shaheen, I think you're on mute. It seems to be that you're muted. We still can't hear you, Dr. Shaheen. It's muted.
Can you hear me?
We can hear you. Oh, now we can't. Can you try one more time to unmute, Dr. Shaheen? No, we can't hear you. It's showing you as muted. So I think it's on your computer. There's a mute, unmute. I'll have to push. Can't hear you. Still can't hear you. Sorry. Are you seeing the mute button on your computer? And it's just not unmuting. Is it saying again that we heard you once for a minute? I don't know what happened there. Maybe try not sharing your screen for a minute and then unmute and see if that gives you the option. I wonder if that just crossing paths maybe. Still can't hear you. Does it show you as unmuted? On your side, yeah. It shows you as muted.
You try press escape, Rolla, top left. Open up Teams.
Oh. Still no. That's okay. Do we want to maybe move to the next presenter and then we'll try and get Dr. Shaheen's sound sorted out in the background? We can't hear you, Glenda.
I think Rolla, because maybe you're full screen on PowerPoint in slide mode. So if you take it out of slide mode, you might be able to easier to see Teams.
She can see Teams. And it tells you you're not muted. It says you can't unmute. And it says, does it say that you can't unmute because you're like, you have to be given permission, like it said originally? Carter, can you right click on Dr. Shaheen's picture down at the bottom? I'm not getting the option to allow her to present.
No, it doesn't let me change your muting settings.
No. Okay. Well, let's move on to the next
I don't
presenter
know
then.
if the next one's on.
Well, maybe you and Kathy then. Rula, do you want to log out of Teams and then rejoin the event? See if
That might work.
If that helps. Although you seem a little frozen there now too. I don't know if you can hear me. But try logging out and coming back in.
Sorry, folks, we're just having some technical issues right now. Bear with us, please.
Try now, Rula?
Can you hear me now?
There we go.
Yeah, we can hear you. Fixed.
Yeah.
Great.
That's
great.
Somebody made me a presenter and somebody, I don't know, it was unmuted for some reason. I couldn't unmute it at all. Can
No
you
problem.
see my
Yep.
presentation? Perfect. Let's try F5. Okay, sorry about that. Thanks everybody for your patience and thanks for the introduction. Today I'm going to talk about approach to challenging breast imaging cases beyond the age, gender, density, size, and shape. The objectives of my talk are the following: to highlight components of patient-centered, high-quality breast imaging practice, present diverse factors contributing to challenges in interpreting breast imaging. I will be discussing the approach to challenging cases through case-based illustrations. As we all know, the components of a high-quality breast imaging practice are the following: radiologists and technologists, the team behind the scene, the breast navigator and educators, as well as the staff, support staff, nurses, booking clerks. Equipments are important, multimodality, protocols, standardized, and the culture of the workflow. This all would feed into an excellent multidisciplinary collaborative care that would improve patient outcome, which would be overarched by the quality assurance program and access to data and research. At the core of this high-quality breast imaging center would be the patient. In my talk, I'll be referring to diverse factors contributing to the challenging cases with the who, what, when, how, and why. Starting with the age, as we all know, age is the most common, like the well-known risk factor for breast cancer. That's why the younger the patient, the lower the suspicion for breast cancer. So we tend to downplay it when younger women present with suspicious findings. Also, there's a tendency to avoid mammograms and limit the evaluation with ultrasound, even if there is a suspicious findings. The increased density in younger patients also would limit our evaluation, especially if there is no access to supplementary screening to avoid the missing of the findings. Women under the age of 50 and above the age of 74, they may be discouraged from screening because really they are not included in the basically the program. However, they're in Ontario, those women can get access to screening by asking their doctors to give them a requisition to go and get that screening done. Add to this the challenges of being familiar with younger children's breast pathology. So really age is kind of one of the challenging factors when it comes to breast imaging. This is a young patient, she's 32 years old, presented with a new palpable lump, pea size. Of course, we started with ultrasound. The tech goes in, scanned the patient, found the nodule corresponding to the clinical finding. And as you can see here, there's an internal vascularity within the lymph node. However, the tech is very astute. She noted that the breast parenchyma in general is kind of heterogeneous and hard. But the patient actually denied that this is an abnormal kind of feeling. Like she feels that the breasts feel the same. She's young. The tech asked me to go in and check the whole breast, not just the nodule. I did, and I also had high suspicion. I asked the patient to go and have a mammogram on the spot. She agreed to it, and we can see that there are pleomorphic calcifications in the upper central breast. And with that, we confirmed our suspicion. Beside the nodule, we also biopsied the heterogeneous appearance mass. And obviously, this unfortunately turned out to be cancer. And you can see here the extent of the disease that was missed on the ultrasound in the beginning in terms of underestimated. It's a really big mass on MRI. Another patient who's 24-year-old with swollen left breast. You can see the skin thickening, the enlarged lymph nodes. Could that be infection because she's 24? However, when we do the ultrasound, we found the mass and there's a lymph node that's suspicious, the skin thickening, got biopsied, also a cancer. We know that the skin thickening can look literally would look like inflammatory breast cancer as well, or infection, but the peau d'orange gives it away. However, the skin thickening on mammogram can be due to fluid overload, such as from heart failure or edema, infection, sometimes also redundant skin, just like in this patient here, which makes it even difficult for the tech to actually handle the breast. And there will be usually a note on the mammogram from the tech that the patient has lost weight and that skin is redundant, which will help us really kind of ignore the finding and know it's a benign finding. This is a 22-year-old woman presented with history of pain in the left breast for 3 months, but she had history of ruptured pectoralis muscle due to injury in the gym, which was a recent history at the time. And she has new skin redness and pain, but no fever. So infection kind of was out of, taken out from the differential diagnosis. Looking at the heterogeneous appearance of the finding in the left breast, we thought probably it's a hematoma. Told the patient to come back in 3 weeks to make sure that it's decreasing in size. We usually follow things up until resolution to close the loop. 3 weeks later, the mass has slightly decreased in size, but really not much as you'd like to see with a hematoma. Another follow-up was done. She showed up after 4 weeks. However, unfortunately, this time the mass has increased massively with internal vascularity. As you can see here, it's invading into the underlying chest wall. This turned out to be lymphoma. So we really need to keep an open mind about other differential diagnoses. This is a 28-year-old presenting with right breast palpable mass and lump, again, starting with ultrasound. You can see the hypoechoic mass. We biopsied it. Obviously, not everything would be cancer. This turned out to be granulomatous mastitis. A year later, presented again with multiple abscesses, multiple masses. All are inflammatory, as we can see here. Large abscess got drained. Then she got referred to surgery to be on antibiotics and steroids. So granulomatous mastitis can be idiopathic or can be secondary complication for TB, sarcoidosis, Wegener's granulomatosis, and diabetes. It's idiopathic, happens between the age of 17 to 42 years old usually, and after pregnancy within the first 2 to 6 years. It is a benign condition but lengthy treatment. Let's talk about some challenges related to gender. The bias of assuming that male breast lumps are always due to gynecomastia. It's very important to know when to act upon them and send to imaging, and even on imaging when to act on a biopsy. Puberty-related breast pain and lumps, that's a common, we get often we get requisitions from family doctors saying that there is a breast lump in a young patient, 8 or 9 years old female, and need to rule out malignancy. And again, the problem is if we do the ultrasound, really you will see a hypoechoic area. It's concerning, but we know it's a breast button. So really, those patients don't need the ultrasound, don't need to get done. They need to be clinically assessed and reassured. Also, it's very important under the umbrella of not respecting patients, that we have to know how to greet our patients, maybe ask them how you'd like to be addressed, and we need to respect their identity. Also keep in mind that some patients have unique preferences and cultural sensitivities. Some patients, women patients in particular, they prefer to have female technologists and radiologists. It's not uncommon that it has come to our attention that some women felt uncomfortable having an MRI, for example, not knowing that they're going to go prone into the machine. Breast will be handled and positioned by a male technologist. They felt unsafe being there in that prone position, going in, not knowing what's going to happen next. I think it's very important to psychologically prepare the patient that this is what's going to happen, what to expect. That would lower their anxiety. This is a classic appearance of gynecomastia in an 89-year-old male, where you can see retroareolar flame-shaped like parenchyma. Even if it goes to, if you end up doing an ultrasound, yes, it looks bad on ultrasound, yet it's a classic appearance in correlation with the mammogram. As opposed to this 64-year-old who presented with a recent history of a lump behind the nipple, it doesn't look as irregular as the gynecomastia on ultrasound. Actually, there's a cystic component. The patient ended up having a biopsy and turned out to be mastitis and abscess. But when you look at the lymph node as well, it's a bit thickened, could be reactive. We recommend a short-term follow-up. However, at the surgical consult, the patient opted to have excision, and that turned out to be benign. This is actually a very fresh recent case that I've done yesterday, where a patient had prostate cancer, where on staging CT, a mass was noted behind the nipple on the right with lymph nodes, which really makes you think of cancer, which is very important. It's not just the classic appearance of gynecomastia. Patient came for breast assessment, and as you can see the difference between the right and left breast, here is almost like a mass lobulated with some speculation, while here it's a flame-shaped appearance. Behind the nipple, you can see the solid mass, also like kind of a bit of eccentricity to the lateral breast, and the patient got biopsied. And here is the lymph node also measuring 5 millimeter in thickness. Chances are that this is going to be malignant are very high. Other challenges are related to density and blind spots. So women with extremely dense breasts have 4 to 5 times greater risk of developing breast cancer compared to women with fatty breasts, likely due to the masking effect or independent factor for developing breast cancer, the higher rate of locoregional recurrence, and the higher rate, as we know, for false positives and false negatives, as well as higher recall rate, which really because of that, we really have to know, be open about discussing the limitations and harms of screening, and not arguing that really the patient should be having the mammogram or do this kind of study or not. Just we need to be aware of it, let the patient know, inform the patient, and have them make their own decisions, because there is an anxiety about the test. We know we should acknowledge the false positive results as well as the false negative results, the overdiagnosis and overtreatment thing that we always read about it, and we are accused of it as radiologists. So having a balanced approach for workflow, as Mark Siegel said, it's not just fear of lawsuits that drives testing. There's a philosophy of practice that encourages defensive medicine. It's part of the culture of not wanting to miss anything or to be criticized for not covering all the bases. But the other problem is the fact that a lot of those malpractices cases arising from the fact of the misconception that mammography detects all malignancies, and any delay will actually make the leads to a worse outcome. So back to breast density, the dense breast, as you can see here, we literally cannot see the tumor. However, on the breast on the right of the screen, you can see the small, tiny spiculated mass in the fatty breast. So this is a young patient. She's 32, high risk, got a screening mammogram and MRI, obviously, under our program. It's extremely dense breast. On the MRI, you can see a non-enhancing, non-mass-like enhancement with mixed kinetics, which was new and prompted second look ultrasound and MRI guided core biopsy recommendation. Here we go. We do the second look ultrasound. The chances are that we're going to see really low, but we didn't see it. Then we recommended the MRI. The patient comes back for the MRI. Unfortunately, or fortunately, we cannot see it anymore. We couldn't re-elicit the finding. So that's probably most likely, given her age, was just background parenchymal enhancement, even though if it was new. So 6-month follow-up was recommended. How about blind spots? You need to learn about your own blind spots when you look at a mammogram. A common one, as we can see here, is behind the nipple. This patient was reported as BI-RADS1 negative, while there is a finding behind the nipple, and your best friend is to compare to previous. You can see that there is a spiculated mass developing behind the nipple on the right when you compare. And unfortunately, it was missed, and the spiculated mass developed. A patient presented 9 months later with palpable abnormality. Ended up with a biopsy, and it was invasive ductal carcinoma and with lobular features. Other challenges related to patient factors due to breast size, shape, which can be large, small, or having an accessory breast. Positioning challenges in patients, especially with strokes, shoulders, and cervical spine issues, MSK issues, and certain disabilities. The techs actually, they are the front line of dealing with all this, and they're excellent with it. And being patient and talking the patient through it will get you a good quality imaging that you can actually report. Breast implants, the systemic conditions affecting the breast, as well as other hardware, including pacemakers and portacath, may result into some compression issues, correct? Like patients cannot tolerate compression, therefore you cannot see high quality images, not because of the tech, just because the patient doesn't want that kind of compression. Here's a patient, a young patient actually, probably I think she was in her early 20s, therefore she had the MRI, and this turned out to be, from the biopsy, a juvenile fibroadenoma, just presenting the case of how masses can be really, really large, and biopsy should be done regardless of the age of the patient, and all sorts of imaging need to be done. Here is a patient with an accessory breast that's sometimes very hard to include on the mammogram. That's why ultrasound is important, clinical examination is important. This patient had an abscess that was actually drained under ultrasound guidance. Large breasts are also a challenge to make sure that they are included in most of the breast tissue need to be included in the mammogram. However, as radiologists, we need to remember to look at all images done by the technologist so that we don't miss the findings. When you look at this image, you would think that the tech did not do a good job, so you wonder, then you read the excellent note from the tech saying, actually, the patient has psoriasis, the patient cannot, she has neck issues, shoulder issues, cannot repeat the images, the best images possible. So really then you deal with what you have and make your best judgment. This is the patient that was called back from screening with a focal asymmetry on the clinical view. When you compare it to previous, you can see it in the posterior depth of the breast, almost central to outer breast. Patient was called back, came and found out that she has a stroke. She was imaged during screening in a standing position, which probably made her not relaxed, and it was very hard for the tech to get a good image, I would say, which led to overlap breast tissue. However, during workup, the tech was the experienced tech actually had relaxed the patient, asked her to scan her during the sitting position. Patient was basically, as you can see, the focal asymmetry is gone and has resolved, and it was negative on ultrasound. Another very challenging case, if you get faced with this on screening and you call back all these masses because you're comparing it to previous, there are new asymmetries. However, if we look back in her history, actually there is a breast hemangioma in the upper outer breast. And to start with, the tech left a note in the first mammogram saying that the patient would like to speak to the radiologist to make sure that she's okay getting the screening. And the radiologist actually documented in the report that it's okay to do the screening. The patient continued to have her screening on annual basis. And you can see here that with the tomo, those asymmetries actually were all pliable, negative ultrasound, and the patient was sent back to screening. This patient another patient came for screening. As you can see here, there is kind of a fluffy asymmetry overlying the pectoralis muscle. And when you look at the patient had bleeding tendency with redness. And then you have no choice but to follow this up to make sure it's not obscuring an underlying mass, which was at that time a hematoma that has resolved after 3 months. Another very challenging case is a 17-year-old pregnant patient in her 3rd trimester presenting with progressively enlarging mass in the right breast. And this is how she looked like during her 3rd trimester. We did the ultrasound. It's a solid mass. Shadowing, got biopsied, and this turned out to be PASH with juvenile breast hypertrophy. PASH is pseudoangiomatous stromal hyperplasia, rare benign disease. It's mesenchymal lesion, and the juvenile breast hypertrophy is also a rare condition that can be of familiar pattern. The gestational gigantomastia is also severe. It's all rare and severely debilitating disease and may result in tissue necrosis, ulceration, and hemorrhage with controversial management. This patient ended up having a reduction, and the surgeon tried their best to kind of make the bilateral breast symmetrical. Some challenges with the breast implants, patients are worried about rupture. This nodule was noted in the left breast and was noted also on ultrasound. And ultrasound-guided core biopsy was offered. However, patients, once she heard that there is a possibility of rupture, which is even though it's very small, she got worried and ended up going for the excisional biopsy, and that was a fibroadenoma. Again, you respect the patient's wishes and fears. Another patient with pushed back views on the mammogram, you can see that there are bilateral concerning findings in the retroareolar region. Both findings were found on the ultrasound. You can see in the right breast and on the left, including the calcifications were even noted on the ultrasound. Patients was offered the biopsies, however, again, opted for excisional biopsies bilaterally, and both cases were, both lesions were malignant. We know that for breast implant, MRI is the way to go in evaluation the issues related to the implants or even lesions closer to the implants, such as the cancer that you can see here in the left image, linguini sign for intracapsular rupture, even an intracapsular seroma, compressing the silicone implant and resulting into enlarged breast. Some women with certain deformities, like this woman had unfortunate lumpectomy with increased fibrosis, which really made the breast tissue, residual breast tissue, shrink, and very hard for the technologist to handle the breast and to get a mammogram. Some women, unfortunately, get very bad reactions from radiation, and it's very hard to compress this type of breast. Women presenting with delayed presentation for their breast cancer fungating tumors, even evaluating their breast on mammogram would be a big challenge. We cannot get most of the tissues. It looks like something like this. Some challenges are also related to certain beliefs. This is a patient that had a nodule in the right breast, which was complex, solid, and cystic, and biopsy was recommended. Patient declined, came back after 3 years. The mass has increased in size, as you can see here, in the lower inner posterior depth of the breast, in addition to other masses. These are actually the post-biopsy mammograms. You can see clips bilaterally, and the mass on the right turned out to be a sarcoma with a papillary lesion as well, with atypical features. On the left, there were papillary lesions with atypia. So it was the patient's choice and has nothing to do with a delay in care or misinformation. Challenges related to equipment and things that we faced during biopsy. I thought I would share a couple of cases. There is, as you see here, in the upper posterior depth of the breast, there is a nodule. As you can see here on the spot compression views on ultrasound was noted. Actually, during the ultrasound, 2 lesions were noted. One of them we're not sure about, but the one that was most concerning was the one in the posterior depth of the breast. So this one here on the right of the screen, and there was an additional one more anteriorly that had the classical features of fibroadenoma. We decided to do a breast MRI guided core biopsy. Unfortunately, given the posterior location, the lesion did not fall within the grid. However, we continued with the biopsy, and it was just anterior to the chest wall. We did the localization, and the patient ended up with a successful biopsy. We left the clip. We confirmed that we got the lesion, and it turned out to be fibroadenoma with atypical ductal hyperplasia, ended up with excision. But the excision did not have any malignant cells. Another challenging case for biopsy was a 72-year-old patient called back from screening in August 2022 to evaluate an asymmetry in the left breast. The asymmetry was nicely found on ultrasound. It's about 8 millimeters, and we were about to start the biopsy. I put in the coaxial, and as soon as we just put it in the skin, the hit a vessel or something, she bled profusely just before we even start putting the needle, the barred needle, to get the biopsy. We sent the patient back and said, come back in a few weeks to repeat the ultrasound and check the lesion. She still had the hematoma, as you can see here. Our navigator worked closely with the patient, making sure that once she stopped feeling and the lesion, the hematoma, and which becomes not palpable, she can come back to the biopsy. So 4 weeks later, she came back and the lesion is visible again. We got it done, and here's a post-biopsy clip, and unfortunately turned out invasive ductal carcinoma. I'm just showing this just to make sure that we follow up with the patients and make sure that the biopsy gets done, because sometimes patients ignore, or they just feel, probably they want to go to another center, but this patient was really understanding that she needs to come back and get the biopsy done. And this takes me to to acknowledge the important role of the breast navigator, who is really the glue to bringing everything together in any successful high-quality breast imaging center. Also, the booking clerks, they have an important role, which is really frontline in patient care and communication. It's very important that they get the needed training, the understanding, including the fact that, yes, breast imaging there are no emergencies or urgencies, yet it is an emotional emergency for many families. It's nerve-wracking to wait to get the workup done. So they need to be empathetic. They need to be understanding, talk to patients, and address their concerns. And when they cannot handle it, they can always refer them to speaking to the navigator or the radiologist. Making sure that you have standardized imaging protocols to minimize errors and enhance consistency aligned with best practices always would be helpful and protect your practice. And appropriate utility of the BI-RADS reporting is very important, because it is the kind of universal communication language between you, the tech, the other colleagues, and the referring physicians. I just want to share and sum it all up through a advocacy message from Sabina Islam, who is actually a brave breast cancer survivor. She's an advocate for early detection and screening. She's also a community builder, activist, and organizer. She's justice, diversity, equity, and inclusion practitioner, and I thought it's very suited for our theme today.
Well, there's no sound on it, on the video.
Oh, is that right? Okay. Can I just quickly unshare?
Yeah, and then reshare.
Yeah. Oh, sorry. I can't. Okay, here we go. Stop presenting.
Yeah, and then share with computer audio.
Yep. I guess I got too excited for being unmuted and shared it without my audio.
That's okay.
1 second. Can you hear it now?
Hi, my name is Sabina Islam. 4
Yep,
years
that works.
ago, I felt something in my breast that wasn't there before and just didn't feel right. Yes, I'm one of those people who does self-breast exams. Not because I'm a hypochondriac, not because I'm paranoid, but because I know I must take care of myself. I had felt something once before and had asked my doctor to have imaging done. I needed to have a biopsy, but thankfully it was nothing. I thought this time it would probably be nothing again. But this time it was different. After imaging and a biopsy, I was diagnosed with invasive ductal carcinoma. Thankfully, it was caught early and was very treatable. I had a lumpectomy and a sentinel node biopsy, removing a lymph node, followed by 30 courses of radiation. I'm still on a regimen of tamoxifen, and I'm happy to report that all my subsequent imaging have shown no signs of cancer. Delaying the inevitable diagnosis wouldn't have made it go away. It would only have negatively impacted my prognosis. I am here today because God willed it. He gave me the confidence to trust myself and advocate for myself. He gave me the strength to work through my fear of the dreaded cancer diagnosis. I feel like I'm also here today because I was supposed to talk about it and share my knowledge to help other women. I wasn't ready to do this in the beginning, but once I was ready, I feel it has actually helped with my healing. My plea to you is to take care of yourself. When it is time for your regular screening, don't put it off. If you feel something before you turn 50, before your regular breast screening starts, take it seriously. Ask, better yet, insist on having imaging done. Don't take no for an answer. Be persistent because you are worth it. Don't think that breast cancer is just a disease that inflicts older women. I was 45 and I know women much younger than me who have gone through this journey. If you have a family history of breast cancer, please ask for screening earlier than 50. The worst that can happen is your doctor will say no, but again, be persistent. As women, we are amazing advocates for our children, spouses, parents, family, and friends. But when it comes time to taking care of ourselves and advocating for ourselves, we sometimes fall short. I'm here to remind you to trust yourself, advocate for yourself, and get screened because you are worth it. Thank you.
Great message from Sabina. I just want to go to conclusion and highlight the important role of multidisciplinary care, which is the way to go for optimal management. And that's why through all these challenges, we have to involve multiple disciplines at some time to survive those challenges. And we need to keep an open mind when managing breast signs and symptoms of young females and close the loop on their complaints and or findings until resolution, and then make or sometimes you need to recommend biopsy. Add timely and utilize adjunctive breast imaging modalities as needed for problem solving to complete the evaluation. I'd like to acknowledge Jill Cummings and Lindsay Justinsky as well as Sabina Islam. Thank you so much for your attention.
It was great. Thank you, Rula. I know you had a few little issues there, but we got through it, which is wonderful. At this point, I'd just like to put it out to our participants. If you have any questions for Dr. Shaheen, could you pop them into the Q&A? We'll just pause for a moment. Okay, there's no questions. Dr. Shaheen, thank you so much.
Thank you.
Our second speaker is Dr. Samantha Feinberg. Dr. Feinberg is a clinical lead for the Ontario Breast Screening Program and radiologist at Lakeridge Health. During COVID, she joined her kids in remote learning and completed her MBA in Healthcare and Leadership and Digital Transformation at McMaster University. She has a passion for system change and providing quality care in the community. She's excited now to be part of the Central East OBSP team, as we are to have you. Please welcome Dr. Feinberg.
Okay, can you hear me okay? Hi, I'm Samantha Feinberg. I'm the clinical lead for the OBSP, and I'm also a radiologist at Lakeridge. So I'm really excited to be here in the capacity as one of the Central East Breast Imaging team. Thank you for having me to speak about different changes in the OBSP that are coming up. So today I'm speaking to you from Toronto, which is located on the treaty territory of the Mississaugas, the Credit First Nation, and the ancestral and traditional lands of the Anishinaabe, Haudenosaunee, Ojibwa, Chippewa, and Huron-Wendat nations. I also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit, and today is still home to many Indigenous people from across Turtle Island. As we are meeting from our locations across the province, we can all take a moment to recognize the land we are on and the original people. My own commitment to reconciliation and the caregivers of this land is to honor the Indigenous right to healthcare, and I will continue to work to improve equity within our healthcare system. Okay, so today this is what I'm going to be talking about. I want to just give an overview of the OBSP, the Central East screening performance since 2020, some screening guidance really specific to COVID-19, some changes happening in the OBSP related to our trans screening policy, and also some future considerations in the screening program related to the Perspective trial, which is a personalized risk assessment trial. So what is the OBSP? It's a provincial-wide organized breast cancer screening program, which we launched in 1990, and it was designed to encourage Ontarians to get screened and lower their chances of dying from breast cancer. In terms of milestones of the OBSP, since 1990, about over 2 million people have been screened between ages 50 to 74 within the program. Over 9 million mammograms have been performed, and more than 55,000 women with breast cancer have been diagnosed through the screening program. So, I mean, these are huge accomplishments of the screening program, and this is really from the collective effort of everyone who works with us in the screening program. So today, this is our current structure. We have the program, and then there's sort of two cohorts in the program: average risk screening and high risk screening, and then we also have follow-up and assessment. So in terms of the average risk eligibility criteria, it's women, trans, and non-binary people who are age 50 to 74 are eligible for screening if they are no symptoms or they're asymptomatic, they've had no history of breast cancer, do not have breast implants, have not had mastectomy, and it's been 11 months since their previous mammogram. Next slide. The high risk criteria includes women, trans, and non-binary people. So at these ages 30 to 69, so it starts earlier than the average risk program, and they can be screened through the high risk OBSP if they have genetic changes that increases their risk of getting breast cancer, if they have a greater than lifetime risk of getting breast cancer based on personal and family history, or they've had radiation therapy to the chest to treat another cancer before age 30 and at least 8 years ago. So the typical cancer would be like a Hodgkin's lymphoma. So this is just a comparison of the two programs. Average risk is ages 50 to 74. And the screening interval is every 2 years for most people, but if you have a history of a high risk lesion or significant family history or high breast density, then you may be screened every year. And then the high risk program starts at age 30. In this cohort, get screened every year with mammography, and most people get screened with MRI. Okay, so I just thought I'd talk about the Central East screening performance. So this has been something new that we've been looking at since COVID, like the screening volumes. So if you look at 2019, that's our baseline. That's the gray line. Those were the volumes we had. Those were the screening volumes for, like, if you look at Ontario and in Central East. I mean, the pattern is very similar. That's kind of our baseline, what we're comparing to. And then the teal line is 2020. That's what happened during the first wave of the COVID pandemic when we stopped screening. And we started accumulating this backlog of people who hadn't been screened during the pandemic. But as you can see, 2021 is the yellow line and 2022 is the purple line. So each region has had different challenges at different times subsequently to 2020. But you can see that the volumes have been really recovering closely, or even at some points above 2019. So this is really like a commitment to the screening team to really help recover from the COVID-19 pandemic. And I know there's been lots of challenges since that April, May in 2020. So now, like, since we've even been looking now at like the screening mammogram, like the mammogram volumes by screen type, which helps us prioritize participants. So so this is just a snapshot from January to September. Blue is the biannual rescreen volume, which really is the bulk of most of the people who are getting screened. The purple is the annual, or people coming back for one-year rescreens. The beige is the initial screens, and the orange, which is our smaller cohort, is the high-risk screen. So that's our screening volume by screen type every month. So you can compare the volumes on Ontario to Central East. You can kind of even see, like, after we're still sort of following what happened in 2020, like the volumes in April, May are like a little bit lower than March. And that's because I think initially because people from 2020 who didn't get screened, we still have a slightly smaller cohort at that time. Okay, next. And then we're also able to look at the MRI volumes for high-risk screening. And you can see in Ontario and Central East, there was that dip in 2020 when we stopped screening for the initial wave of the COVID-19 pandemic. I mean, we did recover faster with the high-risk screening MRI volumes, and that's really testament to the sites really prioritizing this cohort of people for their screens. And you can see, so the gray is our baseline. And then, like you can see in subsequently 2020 and 21, the volumes even went above what our normal baseline is in 2019 to help really, I know it was a lot of effort on the sites to really recover and get these people in for screening. And you can see 2022, we're now we're pretty similar to 2019. And so, like the mammo volumes now, we're actually segmenting out the MRI volumes by risk. The mutation carriers and the people who've had chest radiation are probably the most, even within the high risk, they're probably at the most high risk for breast cancer screening, and that's that orange cohort. And beige is the rescreens, and then initial screens are everyone else is that purple, and then the bulk of the rescreens, which is blue. So these are our monthly MRI screening volumes, and you can see in some months they're really prioritizing the mutation carriers, which are the most at-risk group. So initially we were looking at the backlog, but now we've started looking at more like which participants are overdue for mammography. So this is a comparison Ontario versus Central East. And I mean, the pattern's really similar in Central East to the province. Most of the participants the bulk is people within the 1 to 6 months who are overdue, which I think is likely due to scheduling challenges. They might not necessarily be like significantly overdue, but now we're also able to look at the participants who are overdue, like 12 months out up to more than 24 months out. People are, I mean, one of the reasons is the pandemic, but people are overdue for lots of different reasons. This wasn't something we had necessarily looked at in a lot of detail before COVID, but now we're able to kind of look at this and track those volumes. So yeah, this is another way to look at something similar. These are the participants who are overdue by rescreen type, and then number of months who are overdue. So in Central East, we have like greater than 35,000 participants who are overdue for rescreens, and then we can break it down by month. So, and I would say one reason is the pandemic, but there are other reasons why people are overdue. We really, honestly, we never really looked at it in a lot of detail before 2020. Okay, so I just wanted to reiterate some of the screening guidance we released during the COVID-19 pandemic. We released several documents, some like particularly related to guidance on adenopathy following COVID-19 vaccination, and mammography referrals for participants who turned 75 during the COVID-19 pandemic. So it was reported that COVID-19 vaccines, they report to cause swelling in the lymph nodes. Due to the mass COVID-19 vaccination in Ontario, we released guidance for OBSP sites initially in April 21 to provide recommendations on axillary adenopathy following COVID-19 vaccination breast cancer screening. So the vaccination strategies continue to develop, along with, we know now it's not just the COVID-19 vaccination, it's any type of vaccination, and we have ongoing booster doses for COVID, for flu. So it was most recently updated in January 2022 to address future vaccination campaigns. We can go to the next slide. So I just want to summarize the adenopathy guidance, just to remind everybody about it, since we are going into flu season. We recommend that you still collect the recent vaccination information. It could be COVID-19, but it could also be flu or any other vaccination. It's most relevant when it's in the last 3 months, and provide it to, and just have it available for the interpreting radiologist. Like personally for myself, I don't need a lot of detail, but I want to know when the vaccine was and what side it was on. You can provide participants with information regarding vaccine-related adenopathy. The radiologist should note all suspected vaccine-related adenopathy in their screening reports for the awareness of the primary care provider. And we've also provided like clinical management recommendations for different axillary adenopathy scenarios for the radiologist, and that's also included in the guidance document. We did initially recommend scheduling guidance, although like we understand it's really challenging to schedule people around their vaccinations, considering the ongoing boosters for different vaccinations. So I also wanted to highlight the policy on referrals for participants who are turning 75. So the OBSP screens most eligible people 50 to 74 with mammography every 2 years, and anyone over 74 is required to have a referral for a mammogram from their primary care provider to continue to be screened in the OBSP. But participants who turned 75 during the pandemic 2020 to 2022 did not need a referral for screening, because they might be getting an invitation for screening when they were 74, but due to scheduling constraints, I know for some sites it was difficult to maybe get them in before their birthday calendar year. So the participant should be age 75 at the time of their screening appointment, i.e. they haven't turned 76, and they must meet all the other eligibility criteria. And this temporary policy has been extended until June 30th, 2023. But beginning July 1st, 2023, we will go back to the participant, anyone who's over 74 will need a referral from their PCP. Okay, so I also wanted to talk about the OBSP's transgender screening policy. So in the screening program, we recognize that Trans and non-binary people face many unique barriers and challenges when accessing cancer screening. These are like systemic barriers in addition to any other different types of discrimination they may face when coming to the healthcare providers, but healthcare providers may not understand their needs. There's a lot of infrastructure limitations. Like, you know, our data systems were developed in the 90s, so they weren't really developed. They're very binary. There's absence of very trans-specific cancer screening guidelines. There's not very clear eligibility criteria, and due to like our databases and centralized correspondence, they may not receive the full benefits of a population-based screening program. So all these barriers can contribute to people who are trans and non-binary to not being as up to date with breast cancer and cervical screening compared with cisgendered women. So in 2018, there were overarching policy recommendations to address these challenges, minimize barriers, and improve the screening experience for trans and non-binary individuals. And the overarching policy for the screening of trans people in Ontario, breast screening program, and the Ontario cervical screening program contained 17 recommendations, and a project was initiated to support the implementation of these recommendations in the OBSP. So these are a summary of the policy recommendations. It's relevant to the OBSP. We're going to try to reduce emotional and physical discomfort. Eligible transmasculine and non-binary people should be referred to and screened through the OBSP and the high-risk program. Eligible trans feminine and non-binary people with greater than 5 years of cross-sex hormone use can be referred to be screened in the OBSP and the high-risk OBSP program. The breast implants should not preclude otherwise eligible people from participating in the OBSP, and this would apply to trans and cisgendered women. And 1 year and annual recall criteria should apply to all trans and non-binary people. Okay, next slide. So we're trying to implement these policy recommendations for all screening eligible trans and non-binary people in the OBSP to minimize their barriers to screening and to support inclusion in the organized breast cancer screening program. So we're currently in phase 1 of the implementation. So in terms of our objectives for the next year, we're developing and implementing guidance for OBSP sites on how to operationalize the eligibility criteria on feminizing hormone therapy history. We plan to send correspondence letters to all OBSP participants regardless of sex designation. And this will be more easily applied to the recall and normal results letter once someone presents to the screening program. We will be including all people with breast implants who are otherwise eligible in the OBSP. And we will encourage all our screening sites to provide safe and inclusive screening services. So hopefully this will get implemented. Some of these are moving, some of those goals are moving faster than others, but we're hoping to make some progress next year on the implementation. I also wanted to just highlight the Perspective trial, which is a personalized risk assessment for the prevention and early detection of breast cancer. It's an implementation trial that's going across Canada, mostly it's a Canadian-wide trial, but it's mostly focused in Ontario and Quebec. It's to improve personalized risk assessment to offer cost-effective risk-based screening prevention for breast cancer individuals who are most likely to benefit. So I think this is really interesting because people who have small families who are maybe adopted, who don't have significant family history currently, it would be hard for them to get a good family history. So this would really apply like risk-based assessment on a population level and include people who are probably now likely excluded from a lot of risk assessment. And will also determine the optimal implementation approaches within the Canadian healthcare system. So this is one of the objectives, is to evaluate the acceptability an uptake of breast cancer risk assessment for personalized breast cancer screening within mammography centers. So women ages 40 to 69 who had mammogram at one of the sites that was in the trial were recruited, and they were mailed invitation letters. And also at the sites, there's advertisements about the trial. So some people self-referred into the trial. And anyone who had breast cancer, who had already had genetic testing or counseling for breast cancer, was excluded from the trial. So if you participated in the trial, the risk assessment included a questionnaire about different risk factors, a saliva kit, which was the basis of the genetic testing, and a mammogram report, which incorporated breast density. So all these different factors went into the risk assessment. So it was very comprehensive. Okay, and then across, they recruited about like 2,500 participants. And I think about 1,800 actually completed everything. 1,800 did the saliva testing, and I guess in total they had 1,000 actually. 1,400 did the risk letters and actually filled out the questionnaires. Okay, the next slide. So the people who actually like completed all the different steps of the risk assessment would get like a screening action plan based on their risk levels. They would be stratified into average risk, higher than average risk, or average risk. So if you were considered high risk through this trial, then you would be qualified for the high risk OBSP program. And if you were considered higher than average risk, then you were given counseling about screening starting at age 40. And if you're average risk, you're also given counsel about screening, but recommended to begin screening at age 50. So this was an example of the risk communication letter where they gave information about the participants' risk level, whether it was average or higher than average or high risk. They gave some statistics about the risk of developing breast cancer and how that might compare to the population. So this was an implementation trial. So they weren't like the genetic testing using the saliva kits has been well established for different variants for breast cancer. So they're really looking at how to implement this type of risk assessment at a population level within the Canadian population. So they wanted to examine the screening behaviors, the outcomes, and then we'll have like a bank of like to establish the long-term outcomes of this cohort. So I wanted to, sorry, I'll put my camera back on. Anyways, I want to thank you. I know we talked about a lot of different topics today related to the future of the breast cancer screening program, changes that are going to be happening in the next year with our trans screening population, people with breast implants, the future considerations of the trial with risk assessment, and they also went over like some of the COVID-19 guidance. But if you have any questions, I'm happy to answer them. So I can't really see what's in the chat or the Q&A, so if people.
Okay, Samantha, it's Glenda.
Yeah.
So we're just looking to see if there's some questions,
Okay.
and I think there are. So Namisha, do we have questions for Dr. Feinberg?
Hi there. Yes, we do. We actually have one question for Dr. Shaheen, if we can address that one first, and then we'll follow for Dr. Feinberg. So the first question is, why is BI-RADS 4C if invasive carcinoma on ultrasound image is producing any malignant features? Dr. Feinberg? maybe you can answer that.
So the question was, why are they using? So on the imaging is not like a diagnosis. So we use the BI-RADS to it's the radiologist's sort of prediction of how likely that the imaging findings are likely to be breast cancer. So it used to be just BI-RADS like 1, 2, 3, 4, 5, but now they sort of segmented out like the 4s into A, B, C. So if something is 4C, it means that the radiologist is probably suspecting that there's a high likelihood that this could be breast cancer, but you never know for sure until someone actually has a biopsy and you get that pathology specimen.
Thank you, Dr. Feinberg. Okay, we have a couple questions for you. So the first one is, why do we start screening so late?
Okay, so that's a great question. We've been answering that a lot lately. The screening program is really like a population-based screening program. So it's targeted to the cohort of people who are going to most benefit from screening. And so the cohort between ages like 50 to 74 is the cohort that's going to be most likely to benefit from a population level based screening. But the risk for breast cancer doesn't just start at age 50. Like as we can see, we are using the perspective trial to sort of segment out people who may be at increased risk before age 50 and try to identify those people who may benefit from screening before age 50. So until we can actually do this on a population level, I do recommend people start the conversation with their primary care provider at age 40 or 45 to see if mammography could benefit them for breast cancer screening before age 50.
Thank you. So the next question, with breast implants, we always do a breast ultrasound. How does that impact OBSP bookings?
Okay, so that's a good question. As of now, even though it was part of the policy recommendation to include people with breast implants in the screening program, as of now, we're still working on the implementation of that. So people with breast implants right now are not included in the OBSP program, but I'm hoping that will change soon. That being said, the recommendation will be for mammography screening. Usually we use ultrasounds recommended more for diagnostic imaging.
Thank you. On the next question, why are people with implants not eligible for OBSP?
Well, hopefully that will change next year. The recommendation will be to include people with breast implants. But I think when the program started it was started in 1990. So they made, they're making recommendations for the population. And at the time, when I've talked to other screening programs, they felt like it was difficult to include people with breast implants in the screening program because it does require a more specialized type of study. And it does take longer than the typical mammogram because there's 8 views rather than 4 views. So that might have been some of the reasons why they weren't initially included in the screening program.
Okay, the next question, is there any information on lymphadenopathy on the bivalent vaccine yet?
Well, it's basically now we know that the way vaccines work is that it causes immune reaction. So that can be seen as temporarily enlarged lymph nodes. So I think that would apply to any vaccine. It's basically any vaccine.
Thank you. And our last question, is OBSP considering making vaccine status a question on the questionnaire?
As of now, it's really just more important for the radiologist to have that information for image interpretation and to provide follow-up recommendations. We're not actually collecting that information and putting it in the system for the patient. So that question, I think you're referring to the ICMS question. So we're not adding it on as a questionnaire for ICMS. It's just really for the radiologist so they can give a good professional opinion.
Thank you, Dr. Feinberg.
So I think that's it for questions. There are some people who still might be emailing me some questions. Apparently, there's some people having problems getting into the Q&A to ask their questions, Dr. Feinberg. So we may be coming back to you in a little bit if I get other questions.
Okay.
But thank you so much for your talk. That was wonderful. And we love having you on board in the Central East now.
Thanks for having me.
Thanks. Our next speakers, we have Kathy McLeod Beaver. She is a proud member of the Mississaugas, Ojibways of Rice Lake Alderville First Nation and has been with Lake Ridge Health Central East Regional Cancer Program since 2013 as the Indigenous Navigator. Kathy's passion is supporting culturally safe, equitable access for Indigenous peoples accessing services needed on their cancer journey. Carter Singh is the Indigenous Outreach Liaison for the Central East region. In his role, he works with First Nations, Inuit, Métis, and urban Indigenous communities to ensure their cancer care needs are being supported in a culturally appropriate and safe way. Carter's aims are to prioritize the needs of the community and community members to make the healthcare system a more equitable space. Please welcome Kathy and Carter.
So thank you, Glenda. So yeah, we're going to be talking about supporting Indigenous patients and families through their cancer journey and how to do that in, like you said, a culturally safe way. So if you go next slide. So we also have a third presenter who I'm really excited to introduce. It's Kathy Edwards. She's going to be sharing her own personal story with her cancer journey. Kathy, she'll be going first, and then I'll be following her, talking about culturally safe spaces and how to make your space more culturally appropriate in your practice. And then we go to Kathy McLeod Beaver, who's an Indigenous Navigator, who's going to be talking about her role and how she provides culturally appropriate care for Indigenous patients and families. But first, I want to, again, just introduce Kathy Edwards. Kathy and her family are proud members of the Hiawatha First Nation, and Kathy reached out to us and the Regional Cancer Program to share her inspiring story and message and to further support First Nations, Inuit, Métis, and urban Indigenous people to support those communities, those individuals to have early access and to screening and to cancer support. So with that, I will pass it over to you, Kathy Edwards. Just got to unmute, Kathy.
Perfect. There we go. Welcome. Thank you. Thank you for having me today. I'm just Kathy Edwards. I walk with a foot in two cultures. I live in Hiawatha First Nation, and my husband and children are all members. And I am a proud Scottish cultural background, but we bring those together. So I've been able to be involved with Kathy through my treatment with my diagnosis. So I'm just going to go back and let you know that there was a time when I was, very active, and at about 55, I started getting involved in a little bit more. Actually, it was a little bit earlier, 54. More active. I was starting to run, and I was quite heavy on the top, and so I had I went to seek some information around a breast reduction, and I met with my doctor in Peterborough, and we decided to go ahead with it. In that experience, I had never had surgery before, so I was a little apprehensive, and I was teaching at the time. And what happened was I kind of got a little bit of a cold feet. I phoned the doctor's office and was going to put off this the breast reduction. and was told that, you know, things were changing for the surgeon. She was leaving, she was moving, and that it was probably a good idea if I wanted to go ahead with it, to go ahead with it. So something around me, I actually believe it was my ancestors, pushed me in the direction to get this breast reduction done, even though I was apprehensive. And about a week before the breast reduction, I had been part of the Ontario breast screening program. I had had 2 mammograms. I believe I started a little earlier than 50, and I had one coming up with this breast reduction. The doctor suggested that I had a mammogram right before, so it was about a week before. Came back clear, everything was good to go. I had the breast reduction, and a week after, I got a phone call from the doctor saying that I had been, my pathology showed invasive lobular carcinoma, and that we needed to proceed to see a surgeon quickly because that carcinoma had been opened during the surgery. And so part of the tumor was missing, and with the suggestion that it was probably within me still. And so we needed to proceed quickly. Quickly didn't come really quickly. Of course, you go through all of the CAT scans and you meet with the surgeon, the CAT scans, I did a 3D mammogram, I think that's what it's called. And they still couldn't locate what was happening within me, what was still in there. So I ended up going for a MRI, and it was through the MRI that they found the little flashes of what was left of that tumor. And so we decided to go ahead with a skin-saving mastectomy with an immediate DF reconstruction. So we're talking November was the beginning, and my actual surgery ended up being January, the end of January, January 21st, and this was 2019. And so I did complete that. I went through that. It was great. At the same time, they did a sentinel node biopsy, and unfortunately, they found that it had progressed into 3 of my lymph nodes. So chemotherapy was now not an option. It was the next tool in the treatment plan. So I did 6 rounds of chemotherapy, ended up doing 30 rounds of radiation at Lake Ridge Hospital, and which was a blessing for me because all of my work had been done elsewhere because of the necessity for the speed, I guess. Anyway, I ended up back at Lake Ridge for radiation, which was heartwarming for me because I live in Keene, Hiawatha, just south of Peterborough, and so the travel to my chemotherapy and stuff was rather onerous, and so to have radiation in Oshawa was much better for me. And so currently I am doing awesome. I'm on Arimidex as I was hormone positive, estrogen positive, and I was HER2 negative, which is a bonus. And I have done my 6 rounds of Zometa, and everything seems to be going really well. We did have a little bit of a scare. I do have a mammogram and then 6 months later MRI every year to just ensure that nothing has progressed in, I guess, the back wall and of the breast area. And I did have a little bit of a scare back in June. In my reconstructed breast, they thought they had found something. And so I proceeded with a biopsy, and but it became all clear. It was clear. So my story is this. I go back to, I learned more after, obviously, research, and you don't know what you don't know until you're in it. But I didn't know about dense breasts, and I didn't know about making sure that I knew the steps to take after that. And coincidentally, when I went back to look at my what is it called, mammogram results, it did show that I did have a higher density of breast tissue, and so I now have become an advocate for making sure that the women in my life are well aware that they need to know the density of their breasts, and I have become a advocate to ensure that our men know that breast cancer is possible in their lives and that they need to be aware of that. I am part of the Survivors of Breast Dragon Boat team, which has been a blessing for me. I joined, actually, I couldn't even paddle when I first joined because I was still having the symptoms of the radiation burns. But they have helped me to better understand the use of exercise. Dr. Don McKenzie, who I got to meet in Vancouver in June, was a big proponent of women and exercise. He is out of the University of BC, and he actually began the Dragon Boat push for breast cancer survivors. And so that part of my life has now enabled me to, number one, help to raise funds. I think we recently just raised with our Dragon Boat Festival $202,000 for cancer care in Peterborough and Lake Ridge, as well as to be an advocate and to help women in awareness, men in awareness. Recently was able to present at Hiawatha First Nation last year to women. We were able to directly work with 40 women in understanding more about breast cancer awareness, breast health care, and such. So my diagnosis, although it be very surprising, it was definitely a knock at the side of the head a little bit, became a vehicle for me to be more involved with this awareness and to help women and men to understand the need for assessments, good assessments, further assessments, and the support around understanding their lineage and if there's connections to their genealogy. And that is my story. And I thank you. I have worked with Kathy. Together we have done some presentations, and Kathy actually supported me through my radiation stages, and has been an absolute support for me throughout all of this. And I'm now 3 years clear, and hoping that we are going to continue on. So, and I appreciate the learning that's going on here. I'm actually a retired teacher, so I appreciate the learning and the ongoing learning and everyone's commitment to helping women and men to work through these times. So thank you very much. If you have any questions.
Thank you, Kathy, so much for sitting and taking the time to sit with us and share your story. I think we'll save questions till after me and Kathy go. But yeah, it's always great to have center our conversations on the experiences of patients, of survivors, for our own learning too, right? So I'm going to be talking a little bit about how do we make our practices more culturally safe in the spaces that we work in for Indigenous patients and families. So to do so, we first need to educate ourselves to understand the context in which we work, the context in which patients are entering health spaces. So this diagram is from the In Plain Sight report from the government of British Columbia that they developed in response to the presence of institutional racism in healthcare. And I like it because I think it does a good job of summarizing the report overall, but also in outlining how the health system that we work in is built upon a worldview and a system of knowledge that is exclusionary, that is hierarchical and does cause harm. And to make screening services accessible and safe and effective, we need to challenge these systems and these systems of knowledge, the ways of thinking about health and the services that we provide, so that we can change our practices and to better support Indigenous patients, and for ourselves to be open to different worldviews. So the way we as healthcare workers who have likely received a Western-based education perceive and think about knowledge and think about health and wellness, that is biased based off our education, that Western colonial-based education. It's biased into us into thinking that our way of being, our way of thinking about knowledge, about how we think about health is inherently the best worldview and the best perspective, and the only approach that's necessary. So making all other worldviews or approaches to health unnecessary and not allowed in those spaces. So that's what I mean when I say a Western or colonial system of knowledge is exclusionary and hierarchical. It's putting one above the other. So this way of thinking, it furthers colonial goals of superiority and subjugation, denying Indigenous peoples and communities the option to practice their own traditional practices for health and well-being within a healthcare space or setting, and it entrenches prejudice and stereotyping within the healthcare system. So because we're trained to perceive the world through this colonial lens within our daily lives, within the places we work, stereotypes actually become quite common. They're actually encouraged in healthcare, and this report did find that, as well as many other reports. This is shown to lead to further discrimination. So common experiences include for Indigenous patients and families include their symptoms being ignored, misdiagnosis because of stereotypes, denial of services. All of this works together to create a growing mistrust of the healthcare spaces or institutions for Indigenous communities and individuals. So this in turn leads to Indigenous patients and communities having less access to health services overall. And because of these past experiences of harm, a fear of even accessing health services is developed because discrimination and prejudice that happens so often, that becomes the only expected outcome or experience that patients are expecting when they go into those spaces. And this is, of course, that's just, modern experiences or experiences of one person's life. That's not to say like there's been 500 years of colonization and many institutional harms within health systems, health spaces, and in all institutions. So we have to be very conscious of this history and these experiences and how it leads to a very contentious relationship for healthcare institutions and Indigenous communities. And ultimately, like the diagram outlines here, it leads to poor health outcomes for Indigenous individuals because of the system and the way we think about health. So overall, as this diagram kind of highlights, it leads to poor relationships between healthcare institutions, healthcare workers, and Indigenous communities. Leads to harmful experiences, poor health outcomes, and less access to screening services for Indigenous communities and individuals. So the cycle of harm, it's important to understand because if our goal is to provide culturally safe and appropriate care and to improve our screening services and screening rates, especially for underrepresented demographics like Indigenous communities, this cycle of harm needs to be broken and resisted. So this presents a much bigger challenge to us when we're thinking about screening than you might have originally thought, because we can't improve screening services or any cancer screening supports without affecting the larger system overall, because cancer screening doesn't exist on an island. It's not in and of itself. It's part of a larger system. So if we want to make change, we have to make system change, not just within our own care. So if we go to the next slide, please. So what can we do about that? So starting with ourselves or on an individual level, education, critical self-reflection are always good places to start. These are both important aspects of cultural safety and cultural humility, which involves making a commitment to lifelong learning. So really taking the time to complete cultural safety training, to learn about the history of your local Indigenous communities, about cultural practices, about the history of colonization, just to have a more informed way of respecting and developing relationships with Indigenous patients. And during this process, it's important to always reflect on what this history means to you personally, in your daily life, as well as in your professional practice, and questioning our own power and privilege that we have within different spaces. So critically questioning how our different systems are designed to benefit some while harming and excluding others, and interrogating how we can work to challenge those systems and ways of thinking and different practices and protocols to make those spaces that we work in more safe and inviting for everyone. And that means from both a system level and from an individual level, so one-on-one with a patient, and how we go about providing services. And more than just like cultural safety, cultural humility, it's more than just learning about the history of Indigenous people. It's also a process that involves asking ourselves, like, where do we fit in with this history? Where do we fit in with that present? What is our social location? Or what is our relationship to Indigenous patients or Indigenous communities? Really questioning that, trying to find those answers. And it's not a linear process. You're not going to get it, put 5 minutes a day and you'll just see progress. It takes time. Sometimes it'll happen faster than other times. But the point is, it takes effort. That's what I mean. That's what it means to begin to become trauma informed. It's taking those steps to better understand the context that we live in and work in, and to better understand a diversity of experiences and perspectives and different worldviews. So the diagram here, I think it's just a good example of being patient-centered. So working to foster humility, to build trust, demonstrate respect. Just a couple of things that are helpful to make the change that we want, to empower patients, to be their own self-advocates, to speak up if they feel like they need to talk about like what kind of care is it that they want? What are the protocols that they want to have involved in the care that they receive, and how do you go about doing that? It's also important to include families in that process to help support patients. Important to work with local communities to get that understanding of your own local context. If you're an urban organization, you could work with Indigenous community organizations. If you're in Ontario, you can reach out to your regional Indigenous cancer program, like me and Kathy's. I think every region in Ontario has one, so they'd be happy to help you with this process as well, or at least point you in the right direction. And just lastly on this, I think like cultural safety is both a theory and a practice. So it's not something that ends. So it's great if you're like going and doing cultural safety training, you're doing your own learning. That's needed and it's important, but it's not, you're never going to get to a point where you know everything. That's why we say you have to commit to lifelong learning. Context changes, the present context changes. So you always kind of have to put that effort in. And because it's a practice, you actually have to practice it, right? I guess that's kind of self-explanatory, but just getting a certificate, just doing a workshop, or even attending today, that's awesome, but that doesn't mean you're done, is the point I'm trying to make. So go next slide. So lastly, I just wanted to talk about Indigenous placemaking in healthcare. We're making Indigenous peoples and communities be more visible and respected and celebrated within healthcare spaces. So thinking about the actual physical spaces that we work in and the functionality of those spaces, what the space is used for, and really thinking about who do we have in mind when we design these spaces, and how we work in and move through these spaces. How can we change that to make it more culturally appropriate? And who's represented, whose perspectives and worldviews are represented in those spaces? So just asking yourself those questions with Indigenous communities in mind is kind of the process of Indigenous placemaking in healthcare. So as I talked about just a few slides ago, the healthcare institutions are foundationally built upon Western perspectives of health, and often they're not accepting of different perspectives or Indigenous perspectives of well-being or health, or those different kinds of concepts or understandings. And that is reflected in how institutions look and feel and how we work and move about within those spaces. So it's important for us in our practice to be very intentional in how our environment looks and feels to patients and families so that everyone feels safe, because we know many people don't feel safe accessing those spaces. And that's a issue for access. It's an issue for actually getting the services that they need, and in this case, breast cancer screening. It also helps patients feel empowered to make those choices about the care that they want to receive, the manner in which they receive it. So having things like Indigenous imagery or artwork, something like a medicine wheel can be one way, a small way of doing that. It might include having like a poster visible to patients in a patient's area that states Indigenous cultural practices are accepted in the hospital or within the area that you're in. So something like a smudge or drumming or a song or pipe ceremony. Those might be examples of that. And it comes back to being patient-centered, right? Communicating to patients and families that are there, that you're there to support them and allow them to practice their practices of well-being, traditional practices in that space, if they want. And holding space for these kinds of traditional practices can have a number of beneficial effects for individual patient experiences. So it contributes to cultural safety, developing a culturally safe environment, and Indigenous placemaking by allowing and making space for those types of practices for Indigenous patients and families. It's very important, and especially within an environment that often feels unsafe, where these practices were largely not allowed until more recently, and even still receive a lot of resistance. So making space for that, taking up space, is a big can be a transformative practice. Another example might be hosting larger events, so cultural events. For example, they can have similar effects or similar benefits, but on a larger scale. So it could help by building relationships, by bringing in local Indigenous communities, community organizations, community members into those spaces, allowing them the opportunity to participate in ceremony and culture, traditional practices within those spaces. That also helps foster a culturally safe environment, creating a familiarity with those spaces that are often feeling unsafe, and fostering that feelings of well-being and safety, and that they are in mind when we're designing these spaces. And conversely, for educational purposes with healthcare workers, having those larger events can help expand their worldviews and give them an opportunity to learn and take in a diversity of perspectives. And I think just actually being there in person, taking part in ceremony, in those cultural practices, it's a much different learning experience than just reading about it or watching a video. And actually being there is, I think, much more impactful. So I think if we're trying to make that ideological shift, having the opportunity for people to take part in it is really important too. So to sum, you can see when we're talking about making spaces more culturally safe, even if it's just in cancer screening, it really quickly becomes a much bigger endeavor than maybe you might have thought, right? Because we're talking about system change, and if the entire system overall is making our jobs more difficult to support Indigenous communities and patients, and that's where the change needs to be. Starting with education, starting with that critical self-reflection, those one-on-one relationships you have with patients and families, and then working out, right? What is the policy change that you can do? What are the activities you could take part in or promote or champion, right? How do you support and develop relationships with Indigenous communities? Those are the questions I hope you will start asking going forward. Just to sum there. So with that, I will pass it over to Kathy, who's going to talk about how she does a lot of this in her regular practice every day.
Thanks, Carter. Can you hear me?
Yep.
Good, great. Yeah, awesome presentation, Kathy and Carter. Oh my gosh. So we don't have a lot of time here, but I'll let you read that at another time if you get the PowerPoint slides. But what I will do is talk about, just to build on what Carter's already spoke about, Indigenous practices. So the navigator role came in because of the past history with healthcare system, and that's not speaking specifically to cancer care, but overall, as Carter outlined, that health care has been any kind of institution, whether it's the law, the education system, healthcare system has a power down approach, and has some of our patients and families have experienced trauma going in for test or, you know, to get help. And so that's where my role came in, is to that came directly from the communities. They said, we need help. We need an Indigenous person right in the cancer center when we come in for treatment. And so I've seen firsthand just my presence when patients are coming in the clinic and coming into appointments. There's a sense of relief. I see just a really sense of de-stressing when they see me. And I don't, just because we have a way of knowing, you know, as Kathy was doing her presentation, I shared with her before she started that I was going to light this medicine for her as she spoke, because it takes a lot of courage to speak from this place here, from this heart. And I just want to say I'm so proud and happy to have her in our circle, and that she's come forward and offered her medicine of her story, and helping women become their own advocates. You know, when she was presenting in Hiawatha, you know, I laughed at one of the, I laughed, but in a good way. She said, get to know your girls. That's what one of her messages to the younger women in the audience. And it was making it okay to talk about our breast, to talk about our physical bodies, that this is our vessel. You know, we've been taught in our culture that this is the vessel that houses our spirit. And, you know, and we need to be careful what we put into it and what we do with that vessel. And Kathy's strong advocacy and her strong message to women, it was to empower and to say, hey, I did it. I've been there. And, you know, this is, you know, here's what you can ask. Here's what, you know, because a lot of our people don't like asking or questioning when they're coming into the healthcare system, because they don't want to show disrespect, because that's their past experience, right? When they've asked a question or questioned anything, they were made to feel that they were being disrespectful. And those could be past experiences in other places. It doesn't necessarily mean healthcare. So behind me, I wanted to highlight in our own cancer center at Lake Ridge Health in the DRCC. This is some artwork that the great Randy Knott provided us with to help patients. And you know, that artwork it's not just art, it is medicine. It tells a story, and the story behind this art behind me is it's about the journey. It's about our life journey. And it doesn't just resonate with Indigenous people. When we hung that, we had many non-Indigenous people saying, oh, I feel so good. I don't know why when I look at those pictures, I feel so, you know, so comforted, you know, and that's the whole point of, and when we talk about so what I do, I support people right at the beginning. They may have just come out of emerge and got a scan, and they're, you know, they call me and they say, you know, I've got to go and get a biopsy. Could you meet me there? I'm so afraid. I'm so scared, and I'm feeling anxious. And I go, sure, you know. And so sometimes, you know, I support at that level. I'm a regional worker, which means I travel all over the place. So I'm in Scarborough, I'm in Peterborough mostly, a lot in Peterborough, Northumberland Hills, and of course all of our sites at Lake Ridge. I also travel to the 4 First Nations, which one is where I'm from, Alderville. And Hiawatha is right across the lake from us. And as you know, Curve Lake is north of Peterborough, and Scugog is right close to Lake Ridge in Port Perry. So I also travel into the communities because I learned early on, when Carter talks about relationship, it's about going to them. It's about going out to them. I could sit at my phone and wait for a patient to call me, but I can tell you right now, it would never have happened. You know, still most of my referrals are coming directly from the community. And Carter and I attend many community events just to, you know, it helps to put a face to the name, you know, so now they're more likely to call me or Carter. So Carter gets called a lot to do presentations like he just did in the communities and to help communities build resources. Our screening team has been an invaluable resource to our communities, helping them also develop videos and banners and culturally appropriate materials. So that's why this was really important to me. And my manager, Shannon, actually took my last postcard I had because I wanted to tweak it. And she did this, and I just thought amazing. You know, like she put the medicine wheel on there. And it's things, you know, that is our symbol that represents a holistic approach, that we are all equal. The 4 colors are that represent the 4 colors of man, that everybody in this universe has a role to play, and we were all given instructions by the Creator, and that was our gifts that we all carry. So there's the yellow race, the red race, and the black race, and the white race. Actually, we used to put that black race blue in that circle because that represented them. Because anyway, there's a story behind that I won't get into, but this circle represents that we are all given, we're all lured here from the Creator with gifts to share with each other, to help each other walk this journey. And we were given instructions. Well, as Indigenous people, you heard this a lot, we've been given instructions to and teachings. And, you know, when we were in the spirit world, we were shown how to care for our mother, the earth. So that's our gift. But every one of those colors of man have a gift to carry, and that nobody is above or below anybody. That's what this means. Nobody is in front or behind, but we walk this journey together. And I love that teaching because it's so beautiful. It's such a loving, you know, kind teaching. And so as we, you know, it's been, I will say a lot of the hospitals now allow smudging in our territory. So there's Curve Lake, Peterborough, Northumberland Hills, and Scarborough have all developed smudge policies to support patients. They have bundles there, sacred bundles. And yeah, so this has been amazing. I don't want to take up much more of your time, but Kathy also wanted to mention that she also used alternative approaches, alternative medicines in her journey as well. Yeah, okay. And if there's any questions, but Kathy wanted to use the Q&A to just talk a little bit about that. Thank you, everyone.
Kathy, that was great. Thank you so much. Kathy Edwards, there's a lot of comments there that are just saying to you, thank you so much for sharing your journey. I think everyone really appreciated it. And I believe there is a question for yourself and Carter, Kathy.
So the question is, where can we find more information on Indigenous communities? Is there anywhere we can find educational brochures on how to better assist this demographic?
I would just encourage you, wherever you're, whoever you are, is to ask around. Where's the closest First Nation to me? Is there a friendship center in the town or city that you reside in? These are really great places to start. Also, the Ontario Health have now these teams, and Indigenous communities are part of those teams. Did you have any thoughts, Carter, on that?
Yes. Those are all good suggestions too. I'd say ask the Indigenous Cancer Care Unit. They have a lot of different resources. So you can either just go online, like Google at ICCU. I'll put it in the chat as well. Or you could reach out to your regional cancer program. So like me and Kathy. If you want to learn about the actual area you're in, again, you can Google it, find the closest First Nation or Métis settlement, depending where you are. There's a good website called nativeland.ca. It'll show you what traditional territory you're on, the cultures, the languages that are there, and they have links to different resources. There's a lot of different cultural safety resources. Like a good one is called the SANYAS Cultural Safety Training. It's SANYAS. YAS. I'll put these in the chat as well, but yeah, I just start looking around, right? Like there's lots of resources out now.
You have that link page up there too, Carter, which is a great resource for everyone as well.
Thank you. There's another question. Is there any language barrier with Indigenous patients? If so, how can we overcome the barrier?
I think, like, you know, I've learned this from our patient education lead here at the hospital, Debbie Devitt, is that we have to use plain language when we're speaking with patients, you know, and when you're talking about language, there's translator services out there that are available. I know recently I got a request for support with a Cree patient that was not in cancer care, but it was in our town here close to us and at Lake Ridge. And so I reached out to my community partners and said, do we have a Cree language speaker? And so when I say community partners, in Durham, that's Caria and our Aboriginal and our Indigenous mental health worker, and just people at Nagda Windamug Benojiag, which is a child and family service in our territory. I reached out, I put an email out to all of them. We're all part of a committee anyway, and they gave me several. So I think it's just knowing, you know, those are good questions for the same people we directed you to, like the First Nations themselves and any urban Indigenous organization closest to you. But also, as Carter said, you can call us too. We can help.
Thank you, Kathy. Our last question is actually for Dr. Feinberg. The question is, I know they expanded OBSP to 75 to help people who may have missed their screening due to COVID. Will this continue?
So thanks for asking that question. We did extend that policy till June 2023. So up until June 2023, anyone who's presenting to a screening site who is 75 can get, and otherwise meets the screening criteria, can get screened. But come July 2023, it's going back to the status quo. So anyone over 74 will need a requisition from their primary care provider.
So just to elaborate on that question, Dr. Feinberg, it's sort of related. This person's asking, I want to know why OBSP stops at 75. It creates a lot of confusion. I also find because of COVID, the family doctors are still very difficult to get into, leading to delays in patients obtaining requisitions for OBSP 75 plus.
I mean, thanks for sharing that perspective. I mean, it is a population-based screening program, so it's the invitations and the exception to requiring a requisition for mammographies only applies to people aged 50 to 74. After that time, like the risks and benefits of participating in screening change. So it's really important to have that discussion with your primary care provider about whether screening makes sense for you based on your risk factors or your preferences. So after 74, you require requisition.
That's great. Thank you very much.
Okay.
And thank you to all our speakers. We're going to just take a brief 5-minute break, just so everyone can get up, stretch, go pee, whatever you need to do. And then we're going to continue with Caitlin Mowat. So just give us a few minutes if everyone can be back in about 5 minutes and we'll start. Thanks. Okay, everybody, welcome back. I'm just going to queue up our next speaker, Caitlin Mowat. Caitlin is a certified genetic counselor who currently works with the team at Lake Ridge Health Oshawa in the Durham Regional Cancer Center. Caitlin began her position with Lake Ridge this past May after graduating from Sarah Lawrence College in New York, where she completed her Master's of Science degree in Human Genetics. Her research through her master's focused on the impact of COVID-19 on the accessibility of genetic counseling for remote Indigenous populations in Canada. Prior to attending Sarah Lawrence, Caitlin completed a master's degree in biochemistry and molecular biology at Trent University. As Caitlin progresses in her career as a genetic counselor in Canada, she hopes to continue researching how to make genetic counseling more accessible to Canadians. Please welcome Caitlin.
Thank you, Glenda, for that introduction, and thank you for allowing me to speak today. Before I start my presentation, I want to respectfully acknowledge that I'm on the treaty and traditional territory of the Mississauga Anishinaabe, which is made up of Curve Lake First Nations, Alderville First Nations, Hiawatha First Nations, and the Mississauga of Scugog Island First Nations. I offer my gratitude to the First Nations for their care and their teachings about our earth and our relations. May we honor those teachings. As Glenda mentioned, my name's Caitlin and I'm a genetic counselor with Lake Ridge Health. Today I'm going to be giving an overview of how our genes impact our risk and how we in genetics assess patients' risk and eligibility for the high-risk Ontario breast screening program. So today I'm going to go over quickly the genetic basics, what happens when our genes don't work as they should, and then I'll cover risk assessment tools, then going into genetic testing and the inequities that exist in our system currently using a case example, and then a conclusion as to how we can move forward from here. So for genetic basics, or as I tell my patients, my Bio 101 spiel, what happens when our genes don't work as they should? So cancer is caused by the accumulation of changes, or historically called mutations, to our genes that are supposed to protect us from developing cancer. So our Bio 101 spiel, our bodies are made of billions of cells. In each of our cells, we contain our identical genetic information. That information is packaged into chromosomes. We have 23 pairs of chromosomes. One set comes from mom and one comes from dad. And then in our chromosomes is our DNA, which is packaged into discrete units, such as our genes. I describe these as the instruction manual to our body. They help us tell us about our traits and our characteristics, as well as we have genes that help protect us from developing cancer over our lifetime. So when we think of cancer, we think of it in two different ways in our clinic, and that's how we discuss it with patients. The most common type of cancer is sporadic. It happens by chance as people age and their bodies interact with the environment. Our DNA can be damaged, and that can lead to cancer. When I talk to patients, I discuss this as the known risk between smoking cigarettes and lung cancer. That's our body interacting with an environmental carcinogen that can then develop into a lung cancer. The cancer that we focus on in genetics, though, is the smaller percentage, the 5 to 10%, which we consider to be hereditary. This occurs when we see an individual who's been born with one of the copies of a gene that protects them from developing cancer not working right from the get-go. And so these individuals present with cancer earlier in life, tend to present with cancers at that are more rare, such as pancreatic or ovarian, as well as we see them running in families. So how do we assess risk? Well, I'll discuss an at-home tool that patients can use, as well as the clinical tools that we use to help assess patients for the high-risk program. So what tools do we have in our toolbox to help us assist in our assessments? We'll cover those. And then who may have a hereditary cancer syndrome and how can we determine that based on the information provided by patients? So this first tool I'm going to discuss was just released by the Cancer Care Ontario. It's an at-home patient assessment tool that goes through very similar questions to what we ask in genetics. So it goes through personal risk factors, their age at their first period, how many children they've had, if they've taken any hormone replacement therapies in their lifetime. go over into family history, whether they have any history of cancer. They go into genetics, and they talk about the genetic basics of cancer and some other factors. It's important for me to mention that in that at-home risk assessment tool, ethnicity and background is not a question that's asked. But in the with the OBSP program, as many of you probably recognize this referral page, most patients are referred through for the high risk program through category B, which require a genetic assessment. So they come and see us in the genetics program, and they are referred by their family physician or a provider based on having one of these criteria. So either a first degree relative, a parent, a sibling, or a child who has a gene mutation, such as the BRCA1 or BRCA2, and the patient has either not had counseling or does not want to be tested. And then a personal history that meets at least one of the following. Most often we see patients in genetics that have a personal or family history of 2 or more cases of breast cancer and or ovarian cancer. When we discuss closely related blood relatives, we discuss it refers to first degree relatives, so parents, siblings, children, and second degree relatives, which refer to aunts, uncles, and grandparents. Next slide, please. So the first tool that we use is called IBIS. So this is what the screen grab looks like. This is a program that helps to predict a lifetime risk for an individual to develop breast cancer. And when we say lifetime risk, we say up to the age of 80. Again, this is a cutoff that's been determined based on the life expectancy in Canada and North America currently. So these questions we ask during our sessions, as well as send patients questionnaires prior to their appointments. We ask certain questions relating to their hormone history, age at first period, if they've had any children in their lifetime, and where they are premenopausal or postmenopausal. And then this program really focuses on family history, specifically female relatives that look to see if they've been diagnosed with breast and ovarian cancer. As we know, those 2 cancers can fall together in many hereditary cancer syndromes. And so once we've entered all that data in, we hit calculate risk, and it takes us to the next slide. And so the risk assessment, we get a screen printout like this. And so for the OBSP program, the high risk OBSP program, my apologies, the high risk program, they need to have a greater than 25% lifetime risk of developing breast cancer. And so as you can see here, this woman under the personal risk next to 40-year risk, she's greater than 25%, and therefore she would qualify for the program. We use 25% because it's about double that of the expected population risk, which as we say is about 12%, or 1 in 8 women will develop breast cancer in their lifetime. The last tool that we currently use to help assess patients for the high risk program is called CanRisk, or historically referred to as Bodicea. This again takes into account many personal details, lifestyle factors, the women's health, any children they've had, screening they've had in the past, medical history, whether they've had their ovaries removed or they've had endometriosis, are big questions we ask, as well as if the patient in front of us has ever been diagnosed with cancer. It's important for me to note that this program we can use to assess risk for individuals to have a contralateral breast cancer after they've been diagnosed. The previous tool, IBIS, we can't use for individuals who've been diagnosed with cancer. We then enter the family history, and this gives us information regarding the personal lifetime risk of developing breast cancer. So looking to see is that patient upwards of 25%. This program also gives us a mutational probability, or a likelihood that the patient in front of us has a hereditary cancer syndrome. And so when we do our assessment and the patient meets these criteria, we're able to refer them to have the high risk screening, which Dr. Feinberg beautifully outlined earlier, as they have a mammogram and a breast MRI. And so this is how most of our patients are referred. with individuals who are identified to have a mutation in one of their genes we know that protects them from developing breast cancer, such as the BRCA1 or the BRCA2 gene, they can also be referred to be screened with the high-risk program. And so when I talk about genetic testing and how patients can be eligible through the high-risk program for after they've had testing done, there's current policies we have and guidelines we have in Ontario that allow patients to have covered OHIP-funded testing. And there's, I want to also discuss the inequities that exist and how we assess individuals for genetic testing. So for testing itself, so this is a genetic test that we offer to patients who have either a personal history of cancer. In that personal history, we ask questions about the age that they were diagnosed, the pathology of their cancer, was it triple negative, triple positive, as well as the type, so was it invasive ductal or invasive lobular. We also then ask about family history, taking into account the number of individuals who were diagnosed with cancer, those age at diagnoses, as well as the relationship to the patient sitting in front of us. And so discussing the inequities that exist in our current testing model, it's important to note that most of the time, if a patient in front of us is unaffected, we need to assess their family records to be able to offer them testing. And that can be very difficult for patients who have immigrated to Canada, who don't have well-known family histories, are separated from their families. And so we can use tools in our toolbox to help assess whether or not there's other ways about approaching a family history for a patient. It's also important that we have to discuss the inequities available to access for screening for early diagnosis. And I think as Carter and Kathy put it well earlier, discussing that it can have some trust issues that exist and or delay in the screening because of either not being offered it or not having the proper knowledge that they might be qualifying for the early screening. It's also important to note that our current testing model is Eurocentric, and so about 95% of our genetic data that we use to help us understand the changes in people's genes come from a European population, European Caucasian population at that. So we know the world is much more diverse than just European Caucasians, so it's important for us to introduce more diverse testing databases that allow us to understand risks for differing backgrounds. And so we know in Canada, McGill and UBC are implementing some great research guidelines for genomic and genetic projects moving forward. UBC just finished the Silent Genomes Project, which set out to study Indigenous populations throughout BC and Canada to help them understand their risk for pediatric genetic diseases. But this again can be utilized to help us understand risks in the cancer realm as well. The US has also put together the All of Us research program, which is recruiting 1 million Americans to help create a more diverse health database. This is important that it also, we talk about the inequities in referrals and communication. So meeting the patient where they are, making sure we're speaking the correct language and making sure the referrals are going through to providers that they feel comfortable with. And so before I get into our case example, I just want to briefly go over the potential genetic testing results we can get from ordering a test on a patient. The first result is a negative. We do not find a change in any of their genes that would explain why they or their family have developed cancer. It's important to note that we're still learning quite a bit in genetics, especially as time goes on. And so when we have a patient who tests negative, we always tell them to come back and get tested in 2 to 3 years. So if we have updated testing, with a negative result, we would not alter management or screening, and we wouldn't offer testing to family members. The next result's a positive. This is when we find a pathogenic or disease-causing variant in one of the genes we tested. In this result, we would make screening guideline or screening recommendations, such as referring to the high-risk program. We would also test family members and allow them to discuss with different providers about potential risk-reducing surgeries that might be appropriate for them. The final result is called a variant of uncertain significance, or a VUS, because we really like acronyms in genetics. And so a VUS I think of as a question mark. It is a result that we get back when we don't understand what that change means to the gene's function. When we get that change back, or when we get that mutation result, does it mean that it is indeed disease causing and potentially could be what's explaining the person's cancer or the family history of cancer? Or is it not disease causing and we just haven't seen it enough in the population and unaffected individuals for it to be in a negative? So with a VUS, again, we don't test family members or make any recommendations in guideline or screening changes because we can't really, with the uncertainty, it's hard for us to know how it would impact the patient. And so with that in mind, I just want to go over a quick case example that we saw in the clinic. So this was a 56-year-old Jordanian woman who was referred to us from her oncologist. She is the bottom circle there with the arrow pointing towards it with the stripes through her circle. So she was diagnosed with breast cancer in the left breast at 50 years old, received a lumpectomy and radiation. Following that, at 54, she was diagnosed with a right-sided breast cancer. So now she has a bilateral breast cancer. And she was treated with a lumpectomy, radiation, and currently was on endocrine treatment when we saw her in the clinic. And so with this woman, we asked her about her family history. We already had her personal medical history from her chart. And so we discussed that she had her father had passed away at the age of 50, and there was potentially 2 cases of unspecified cancer in her cousins, so her dad's siblings' children, over the age of 70. So not very suspicious in that realm. But looking at mom, who is the circle above her with the line through it, she had breast cancer in her 30s, which is quite young, and had passed away at 40. Outside of mom, there was no other reported maternal family history of cancer, but it was a very small family, which can hinder our ability to assess. Next slide, please. Yeah, perfect. So we have hereditary cancer genetic testing guidelines in Ontario. So there's 8 guidelines that a patient can meet that we would offer OHIP-funded testing. And so in yellow are the 2 criteria that the patient met. A patient only needs to meet one of the 8 criteria to have a assessment of or with genetic testing ordered. So she met 3, which is a personal history of breast cancer at or under the age of 50 with a second primary, so her left-sided and right-sided breast cancer. And she also has a personal history of breast cancer with one close relative, her mom, who was diagnosed with breast cancer under the age of 50. And so with that, we offered her testing and we got our results back, which are on the next slide. And so she came back with a variant of uncertain significance. So again, as I mentioned, with a VUS, we're not making recommendations and screening changes, and we're not going to be testing any family members. But it's important, again, to reflect that we also have a very Eurocentric genetic testing model. And this woman was not from Europe or Caucasian descent. She was from Jordan. And so with our genetic test results, we got an interpretation from the lab, and they went through, as you can see here, with the information that's underlined. This had been found in individuals from Christian Arab families from northern Israel who had been diagnosed with cancers in their lifetime. And so we did a little more digging because the family history and her personal history were quite suspicious and quite suggestive of a hereditary cancer syndrome. And again, knowing that this woman doesn't come from a Caucasian background, again, it's important for us to dig a little deeper. And so before I get into what it meant for us when we did the literature review, I wanted to go over the cancer risks associated with the BRCA2 pathogenic variant. The woman previously had been diagnosed with a BRCA2 VUS. And so when we know there's a mutation detected, we know that females have a risk of upwards of 60% for developing breast cancer in their lifetime. We know the average woman's risk is 12%, so again, quite significantly elevated. We can see male breast cancer in individuals who have a BRCA2 mutation. The average risk for a male breast cancer is less than 1%. And in a BRCA2, we know it's upwards of 7.1 by the age of 70. So a high risk individuals that would qualify for increased screening. And then the ovarian cancer risk, there's an increased risk of upwards of 29% for these patients, which the population risk is about 1%. And then there's also prostate cancer risks and pancreatic cancer risks. Also important to note here in yellow, if the patient had found to have a pathogenic variant, we would have offered testing to her first degree relatives because they all have a 50% chance of carrying the same change she does. That would include her children as well, which she was expressed concerns about during our appointment. Next slide, please. And so diving into the literature, we were able to reclassify her variant. We were able to see that 35 unrelated individuals had a history of breast cancer, and 5 out of those 35 from the region, so Northern Israel and Jordan, were found to carry the variant, and then 4 out of the 5 were affected with cancer at the time of the testing, and the 1 of the 5 that had not been affected with cancer at that point had a mother with ovarian cancer. And so with that information, we were able to classify it as a pathogenic variant in our clinic, which then allowed us to make recommendations for the woman. And so after review, we were able to then, as I mentioned, treat this as a pathogenic variant. The patient was offered all of the follow-up as if she had a positive result. So she was referred to the high-risk breast screening program to have her annual mammograms and breast MRIs. We discussed the option of a bilateral mastectomy. And as well, we had the possible eligibility for targeted therapy with a recurrence, such as in some cancers, the PARP inhibitor can be used with a BRCA1 or BRCA2 mutation. We talked about a referral to a gynecologist to discuss an oophorectomy or removal of her ovaries so that it would reduce her risk for ovarian cancer over her lifetime. And then we offered targeted testing of the family variant to other family members, specifically her children. And again, if her daughters were to test positive, then they would be referred to the high-risk program as well. And so with that context, we know that our current testing models aren't a one-size-fits-all. And I also wanted to discuss the disparities that occur in breast cancer outcomes for other populations as well. So we know that triple-negative breast cancer accounts for approximately 10 to 20% of breast cancer cases diagnosed. It is known that triple-negative breast cancer is a type of breast cancer that disproportionately is diagnosed in Black women. This study came out of the US. A lot of our research is currently US-based, so I just want to have that caveat in here. We know that European descendants have a 16% frequency of having triple-negative breast cancer, while Black Americans can have a 30% frequency of being diagnosed with triple-negative. So that's about double the risk for Black individuals. We know triple-negative breast cancer is generally earlier onset, more advanced stages at diagnosis, and aggressive with poor response to conventional treatments, leading to a poorer prognosis. So with this disparity also being seen in the worst clinical outcomes for Black Americans at the time. And triple-negative breast cancer itself is, or due to the other disparities in healthcare, including the fact that we know less about the population and therefore it might not be offered testing or screening based on what the information we have now. So in studies which looked at the disparities, it is hard to pinpoint one contributing factor, and many researchers discuss the socioeconomic factors alongside with the understudied genetic factors. So socioeconomic factors include limited screening, delayed or incomplete treatment, lower participation in clinical trials, as well as lower income and education, so patients not presenting to screening or not trusting the screening at the time either. And so we also know that there's genetic factors at play. BRCA1 has a very high chance of having a triple-negative breast cancer when the breast cancer is diagnosed. And so we know, coming back to our example that we talked about earlier, that we don't have great data for non-European populations. We are drastically improving that, which is nice to see, but it can be hard if there's no hereditary cause being identified in the individual or the family, which again might delay screening in family members and management in the future. So I always like to think about the modifiable and non-modifiable factors. So the modifiable factors are ones that can be through education and outreach and making sure that we're making the screening options and conversations accessible for all of our patients. The non-modifiable factors would include the genetic risk, but we can identify those to help individuals understand their risk and therefore modify maybe lifestyle factors that might be at play. There's also, as I mentioned earlier, we used the at-home risk assessment model by the Cancer Care Ontario. Boston University just put out a risk calculator for Black women to help them tailor and get a greater assessment and understanding of their personal risk. And so with that, I just want to go over some conclusions and where can we go from here? What's important to ask the patients that are in front of you? So I always recommend ask about the family history if they don't know or if they're unclear about certain cancers and it's in women or at a young, always recommend that they be screened or sent to genetics to see if they have potentially a hereditary cancer syndrome or if they would qualify for the high risk program. We need to educate patients and providers about risks and the genetic basis of cancer to help us understand and inform those that would benefit most from screening and genetics. Ensure individuals have access to screening and services and the access is appropriate for them and something that they want to move forward with. In genetics, we never take results at face value, especially in non-European descendants. And we also want to ensure that we're continuing to increase representation in research and in clinical trials. And with that, I want to thank you for listening. If you have any questions, please don't hesitate to ask.
Just give it a moment. Thank you very much, Caitlin. That was awesome. We're just going to see if there's any questions in the chat. So just bear with us for a moment. Great. Thanks very much, Caitlin.
Thank you.
So, oh, wait, there is a question. Okay, apparently there's a question. Come back.
So the question is there any possibility the genetic testing will be accessible to all general public who wishes to have it done?
Yeah, so right now at the Women's College Hospital, so the accessibility right now is it's private pay, so it'd be out of pocket for patients who don't meet our clinical criteria. It's $300 out of the Women's College Hospital. There is a push right now that every woman should be tested for the BRCA1 and BRCA2 genes, but right now it would have to be private pay. It's not accessible and it's not covered unless you meet the criteria. I hope that answers the question.
Great, thanks, Caitlin. Okay, so I'm going to introduce our next speaker now. We've had a little bit of a glitch here, so Louise has called in and she's going to be talking to you all from my phone. I'm just going to get my phone hooked up there. Okay, so our next speaker is Miss Louise Miller. Louise is the founder and former director of the Mammography Practicum at the School of Medicine, University of California, San Diego. She was named as the Honorary Fellow for 2017 by the Society of Breast Imaging. She currently serves on the National Mammography Quality Advisory Committee for the FDA and NQSA. Following this appointment, she was diagnosed with the triple-negative breast cancer. Her diagnosis, treatment, and recovery has provided her with an additional level of commitment, experience, knowledge, and compassion as an educator. As a Director of Education for Mammography Educators, Ms. Miller continues to provide education and consultation on mammography quality standards and positioning throughout the United States and the world. Please welcome Louise Miller. Go ahead, Louise.
Glenda, your microphone's on mute, so we can't hear Louise.
Let's try that again. Okay, Louise, my apologies. No, there's just barely? Okay. Where's my microphone here, guys? I got this up as high as I can go. Okay. A little bit? Okay. Talk nice and loud, Louise. Yeah, that's as loud as it'll go. How about now, guys? Can somebody else answer to see if we can hear Louise?
No, we can't hear Louise. I wonder if she calls the work phone number instead of the cell phone number. You might get better audio that way.
Okay.
Glenda, is your phone on speaker mode?
Yeah,
Yes,
Glenda's
my,
phone
my
is on
phone's on
speaker.
speaker, yes.
I got off speaker. Did it go on speaker?
No, they wanted to make sure I was on speaker. Sorry, guys, another little glitch. 1 second. Again, folks, we're just having some speaker problems with Louise connecting from the US. She's calling in on my landline to see if this is any better. Bear with us. Okay, we're going to try and unmute and go say something there, Louise, to see if we can hear you.
Hello, hello.
We can hear you beautifully. Go for it. Okay.
Thank you for inviting me. I'm always very pleased to get a call from Glenda to ask me to participate in this program for you all. But also too, I have to tell you, Glenda asked me if I would pre-record this, and I was very insistent that no, I wanted to do it live. And let me tell you why. I knew there were other survivors sharing their experiences, but I really appreciate it, and I learn from also. But then that gives me an idea of maybe some things I don't have to talk about that they've already covered. So sorry for the glitch, Glenda. I should have listened to you.
It's all good.
Here we go. Next slide. The goals and objectives are to describe procedures that breast cancer patients experience, to list common side effects of chemotherapy, to explain emotional responses patients may have to diagnosis and treatment, to demonstrate how emotional and physical responses affect patient behavior, create a more compassionate understanding of patient needs, which the other speakers have so wonderfully spelled out and identified, and what a great job you all are doing. I mean, it's just, I was so impressed. Anyways, also to implement appropriate communication skills. So this was my sequence of events. I was diagnosed with triple-negative breast cancer in August 2017. So I will be a 5-year survivor in June of 2023. And one of the things that I learned is survivorship is, or the number of years that survivorship is based, is on when you end treatment, not when you're diagnosed. So just that's a little point of information. So I had all the things everybody else does, everybody else described. I had a screening mammogram. Yes, I was late, of course, just like all healthcare professionals. Actually, I was talking to my daughter yesterday, and she said, oh, I got yelled at for not having my mammogram. And I was like, Erin, she goes, well, you were just as bad, that I was only 4 months late. But 4 months, you know, didn't make much difference, I think, in the end diagnosis, but especially with triple-negative breast cancer, you want to get in there and find out early, you know, so super important. And obviously, you don't know what kind of breast cancer you're going to have until the diagnosis is made. But anyway, screening mammogram, additional views, ultrasound guided core biopsy, stereotactic biopsy because I had gout besides a small mass, then diagnosis, treatment plan, then of course, being the very, how can I say, insistent person I am, I got second, third, fourth, fifth, sixth, probably seventh and eighth opinions, and then started my treatment and medication. Also too, I had my port placement. I had 12 rounds of chemotherapy. And by the way, when people talk about rounds, I didn't even know how you get chemo, okay? Here I am working in breast cancer detection side, but I didn't know that much about treatment. So I didn't even know what a round meant. A round meant, what it means is how many times you get that treatment. Okay, so I got 12 rounds of chemotherapy, and you get a round of chemotherapy just once a week, okay? Then I had MRIs, or before and after MRIs, then I got more chemo, what they call the Red Devil or AC. I got 4 rounds, and usually they do AC because it's so strong every 2 weeks, okay? Then I got what's called a neutropenic fever. I didn't even know what it was. And soon became, when I experienced it, came to find out that something called a chemo crash. Anyways, I had a wireless localization after my chemo. I had sentinel node procedure, lumpectomy, and radiation therapy. And it took me from the diagnosis end of August until the 1st of June to get all that done, okay? And kind of having an inside track on breast cancer diagnosis and treatment, and having worked at the University of California in San Diego School of Medicine for over 30 years, I was hopeful that they moved things along fairly quickly. But unfortunately, I did not have the super positive experience that a nurse navigator provided. Actually, nurse navigator never even contacted me, and I don't know if that's because they thought I had the inside track and I didn't need any help, but boy, I could have used that. That's such a valuable service. So with medication, I'm not a pill kind of person, but I'll tell you what, this is probably what my bathroom thing mostly looked like. I got pills and more pills and pills for this and pills for that and pills for everything. So that was something I probably wasn't really prepared for. Also, too, I had never had a breast MRI. I'd gone in and seen breast MRI biopsies. I'd seen the procedures performed, just a breast MRI, but I had no idea the experience that a patient has. And let me tell you, when women talk about wanting to have screening MRIs, and they're like, well, you know, you have to have an injection for contrast. And I go, oh, I don't care. It's better than having your breast squeezed. Well, if you've ever had a breast MRI, you know it's extremely uncomfortable. And it's not because your breasts are like hanging, you know, pendant into the machine. It's because your whole body, the weight of your upper body is on your sternum that's pressing like against a little bar that's about maybe, I don't know, 8 inches long. And even though they had that bar, let me tell you, it's extremely uncomfortable and my pain tolerance is pretty high. So that was something I had no idea about. Let me tell you, when I got my second MRI, I'm like, oh God, I really dreaded it. Also too, it's loud, it's long, it takes 40 minutes, it's hot, you know, so not a fun experience. So that was something I had no idea, something new that I learned. Here I am, I had a wireless localization. I had the Savvy Scout, which, you know, is like a radar reflector, and they had to bracket my tumor. So here is the only patient in the history of the entire universe smiling during her procedure, letting people take pictures. So here I have, prior to my lumpectomy, having my tumor bracketed. And here's the radiologist who's checking the position of those tiny radar reflectors. And here you can see super freckled, laid in the sun too much when I was 16 years old in Southern California. So anyway, here I am, here a little baldy. It's hard to remember that, but remember, all this is done after chemotherapy, all right? And your radiation therapy is done after you have your breast surgery. So what they try to do is shrink the tumor. So now I had never had any type of nuclear medicine scan done. I had actually helped do the FGI, but here, this is a whole different story, guys. I mean, you can imagine a patient who's not familiar at all with any type of body imaging to be under this huge thing that's passing over. And of course, I'm just like every other curious patient, but I got to take pictures. Here you can see the little radar reflectors lighting up in my breast. So super cool experience. And this is for the sentinel node biopsy. Okay, so typical feelings on diagnosis. Well, first of all, I was pretty mad. Well, no, first of all, I was shocked. But then I was mad because I'm like, wait a minute. I've lived my whole life dedicating my professional life, at least, and most of my personal life to, you know, breast cancer detection. And I think we all, as mammographers and healthcare providers, you know, think that somehow we're supposed to be protected. But I've learned pretty quickly over the years with having so many friends who work in the business diagnosed with breast cancer that I was kind of mad after the shock wore off. So that's a very typical feeling, the typical why me? And then you get scared because it's just like, well, how am I going to navigate this? And sometimes, you know, no knowledge is better than more knowledge, and it works both ways. But I didn't know a lot. Again, I knew very little about treatment. And so it's like I had no idea what was in store for me. I felt helpless. Again, that it's not fair thing, and why me? And then I felt guilty, and I felt guilty because my family was going to have to go through this. And my niece, Sally, was diagnosed with triple-negative breast cancer 15 years ago, and I know that how hard that was on my sister, who was her mother. So here's my poor mom, who was 95 years old at the time, super healthy, super aware. And I felt so bad that my mom would have to worry about me. And so you do feel guilty. And my daughter, the people who love me, would have to worry about me. So you do feel guilty. Other feelings is you get crabby. I could be very crabby. I'm usually in a very good mood all the time, but boy, when we have our patients snap at us, sometimes we're having a mammogram, we're like, what the heck is the matter with them? Well, guess what? They're crabby because they're scared. They're weepy because they're scared. They're argumentative because they want to get control over a situation. They don't talk at all. I mean, I am a talker, and sometimes I just didn't want to talk about it. And the really hard thing for me is that I worked the entire time through my breast cancer diagnosis and treatment. So when I'm lecturing on finding breast cancers early on mammograms, and I'm talking about invasive breast cancers, and I'm talking about triple-negative breast cancers, I could never get away from it. So I didn't want to talk about it when I wasn't working, and of course, everybody's so concerned and curious, and sometimes I just didn't want to talk. Now I understand how patients can sometimes be rude. And it again, isn't something about you, it's about the situation. And somebody described earlier that, sometimes you can be timid. You're afraid to ask questions. I didn't want to look stupid. Here I work in the business, but I was afraid to ask questions. The causes of the typical feelings were the effects of chemotherapy, the baldness thing, the fear of losing my breast or both my breasts. What does that mean, to me? The fear of dying is something that you kind of try not to go to, but it's ever present. Again, just hearing the last lecture on genetics, every time I hear somebody say triple negative, it's like, when you hear somebody say, triple negative, it has a, lower response rate, it has a lower cure rate, has a higher mortality rate. Every time I hear that, my heart flutters a little bit. The lack of knowledge, again, there were so many things I didn't know. The misinformation that we get and the appointments, so many appointments and so many long waits. No wonder our patients are crappy by the time they get to us, okay? Now, what people usually know, and this is what I knew about chemotherapy, I thought about people who are in the grocery store and need to find a trash can to vomit in. That was my idea of chemotherapy and nausea. The other thing I knew for sure about chemotherapy is that you lose your hair, and you usually lose all your hair. Okay, you lose your hair, you lose your eyebrows. The good thing is that you don't need to shave anymore. No bikini waxes. Not that I'm running around in bikinis, but the best part is that you don't have to shave your legs, right? All the hair goes. And even to the point, it was so funny. I was talking to my oncologist one time, and my nose was running all the time, and I couldn't figure out what it was. And she said, well, that's, Louise, because you lose all those little hairs inside your nose, not to be gross, but to keep your nose from running or the boogers from running out aren't there anymore. So you've got no hair inside your nose, so your nose runs. So I knew nothing. It was not just nausea and hair loss. But let me tell you, when you think about losing your hair, that's a very scary thing. Glenda, are you with me on the slides? Do I need to be telling you when to change?
Sure.
Okay.
We've got the big, it's okay, and we've got the big fear one up right now. Do we need to?
Anyway, I hate to say it, we all go, I don't care if I lose my hair. Oh yeah, we do. Our hair is such a strong part of who we are. And the thought of losing it, I can wear my hair is long, I can wear it in a ponytail, I can put it up, and in the 60s and 70s and 80s, I was putting hot rollers in it, and I loved fiddling around with my hair. And the idea of losing it altogether was just awful. So what I decided to do is to try to have fun with it. So I invited all my girlfriends to like a happy hour at a wig salon. And actually the owner of the wig shop told me that I could bring in wine and hors d'oeuvres. And so I invited all my girlfriends, and they all got to pick out wigs for me to try on. And this was not me. So I'm not Barbie. So that wig didn't make it to the final vote. However, this one, I was like, okay, let's
Next
do
slide.
J-Lo. Next slide, I'm sorry. Mermaid wigs. So that was my idea of how I thought I was going to look. But these wigs are like, you guys, sometimes $10,000. And it's like, hey, if I'm spending $10,000 on a wig, I better look like J-Lo too. So anyway, that was not an option. Next slide. Everybody thought it would be cute that if I had colored wigs, but again, not an option. So I got a couple wigs and I wore them, and I hated wearing the wigs because guess what? They're hot and they're scratchy. And so most of the time I just decided to do the bald thing. But what happened as rather than go completely bald, because my hair was like shoulder length. Those of you who know me, and sorry, you can't see me today, but you know, my hair is below my shoulders. And so I thought, I just can't go from 0 to bald. So what I decided to do is cut it short. So here am I looking like a troll doll. Next slide. And that's exactly what I reminded myself of. However, after chemotherapy, my hair started growing in, and it was black and gray. You know, who knows? I've been dyeing my hair for a million years, you know, but I never thought black and gray. And it was curly, like most people said. So that was probably the best part after chemo, is all I had to do is get out and, you know, or wash my hair, get out and, you know, towel dry it, and then just go. But I'm not a short hair girl. So it took almost 3 years to grow my hair back to its normal length. So it takes a really long time, and it's hard. What most people do not know is the chemo experience. Okay, the chemo experience is like, here we have all these, you know, chemo patients. I'm sorry, next slide. Here they're all sitting in the treatment room, men and women together. You know, men are getting chemo too. So it's nice that a lot of breast centers now have places where just breast cancer patients are. But the chemo center where I was had like 200 people in it. And when I walked in the first time and I saw all these people in various stages of cancer, most of them very ill, like falling out of the chairs with their IVs on, I was like, oh my God. And I started to cry. I'd never been in an infusion center. And I remember the nurse saying to me, why are you crying? And it was like, why do you think? I mean, I was in shock because, remember, this was before my hair loss. And I felt good. I thought I looked pretty good, you know, looked healthy. And so the first few times I was there, I was like running around, you know, the chemotherapy. I took my IV pole and I thought, well, I'll go and visit people who don't have any visitors. But once the effects of chemo takes over, your energy really saps. And chemo also is an all-day experience. You go, you get your blood taken, because if your red blood cell count isn't high enough, you can't have chemo. So I had to wait 2 hours to get the results, and then the chemo procedure took anywhere from 3 to 5 hours. So it's an all-day event, and people wanted to go with me, but I said, okay, you can come if you bring lunch if I was hungry. But I said only people could stay, one person each time, and only for an hour, because I was exhausted. You know, and sometimes it's just hard to make conversation, even though these are my dearest and closest friends. Like I said before, sometimes you just want to be quiet. So here is what they call the red double. And I actually sent this picture to my sister. I said, oh, look what they're doing now. And she goes, Louise, I said, look at all that red stuff. And it was like 4 bolus injections, and this is AC. And she said, well, Louise, I'm not so much worried about what they're putting into you, but she says, look at the hazmat suit that the nurse was wearing. And it's true. They're putting poison in you when you think about it. So this was the very first one, and this is the very last one. So I'm sitting here, of course, with my iPad. I'm working. I gained a lot of weight during chemotherapy, and I said I was the only person ever that gained weight during chemo. But I just felt, well, food has always been comforting to me. I've always carried extra weight, but I really packed it on when during that whole process. But that's okay. We're getting back to normal. What most people do not know is that anemia is a huge problem. Your red blood cell count goes down, okay? You have appetite changes, you have bleeding problems, constipation, diarrhea, fatigue, and you can get serious infections. Next slide, please. So this is really, really important. This is why they do your red blood cell count prior to infusing you with chemo, because obviously your chemo is going to knock out your good blood cells. So if you're super low, they will not do the chemo. I didn't even know that. Okay, so it's extremely important. And what happened to me is my red blood cell count was right on the verge of where it shouldn't, it was so low, they were questioning whether to give me an infusion and or whether to go ahead and give me the chemo. And I was in a hurry, and I said, how long will the infusion take? And they said, oh, it'll be another 4 hours. I said, forget it, just give me the chemo. Well, not a good decision, because I got something that's called a neutropenic fever. I didn't even know what this was. And what it was is my red blood cell count and white blood cell count dropped so low that I was put in intensive care and had 4 units of blood infused within, I think it was the first 24 hours. I almost died. I had no idea how serious this was. So just know, infection, they have no idea how I got the infection. You can cut your finger. This is why they don't let you have flowers. If you have this type of infection or you're having chemo, they don't let you, have flowers delivered from florists because the water is so high bacteria, so much bacteria in it. So who knows? I may have had a cut on my finger. I was fiddling around in the garden or something, but boy, I was sick, really, really sick. So most other things that people don't know about chemotherapy, you can have mouth, throat, and nose sores. Okay, as I said, my nose was running all the time, but I got these sores inside my mouth. I had nerve changes. You get neuropathy. I didn't have in the beginning, but then I found myself one day I was trying to button a sweater. It's like, why can't I button this sweater? Because I had neuropathy in the tips of my fingers and my toes. Most of the time, chemotherapy doesn't hurt, but people can experience pain, sexual changes, swelling, urinary changes, memory changes. Next slide. And I had always heard about chemo brain, okay? But I was like, I don't have that. I'm just fine, until I had lunch with my grandsons one day when I was talking about a restaurant that I would like to take them to, and they're looking at me and they call me Wheezy, and they go, Wheezy, you've taken us to that restaurant 10 times. And I was like, oh, I have. So chemotherapy is a real thing. And I love this. This is a classic example. Next slide. If I had $1 for every time I got distracted, I wish I had some ice cream. That's the classic example of chemo brain. Okay, so radiation therapy. I didn't know, I had rotated through radiation therapy as an X-ray tech. But what they did, they talk about rounds of radiation therapy. But you get radiation therapy every day. Okay, so I got 3 weeks. I think not on Sundays, but you go, no, I think, okay, I'm trying, I have chemo brain. Okay, you go 5 days a week, you're off on the weekends. And so I had 15 rounds. Okay, so that's 3 whole weeks of radiation therapy every day. And it only takes like 5 minutes. And I lived an hour away from the hospital, so it took me longer to drive there and drive back than it did to get my radiation therapy. And then I had 1 week of what we call a boost, okay? So that's just to make sure that all the cancer cells have been killed. And here I am getting my radiation therapy. You guys probably all know what the machine looks like, huge machine. And again, you're just in there a short period of time. Here I am here with my right breast. And this is after my lumpectomy. You can hardly see any changes, and I'm going to show you a picture in a minute. But next slide. Oh, here. People have told me about radiation burn, and this is as bad as mine got to be. Okay, so and they just give you an ointment, but I didn't have a super bad problem with that. Okay, next slide. What most people don't know also is the emotional side effects of having cancer. Next slide. Common emotions during and after treatment are concerns about chronic health problems. What do I do next? Frustration with physical changes or new limitations. We all know that a radiated breast can continue to change for up to 5 years. and mine has. I can tell you, I was, it's not that I'm staring at my breast all the time, but, I've noticed a change between what I see in the previous slide where you saw the slight radiation burn and how my breast looks now. It's not the same. Okay, so, but I'm not frustrated, but still, it's a change. The sense of grief or loss over others being diagnosed so close to home. The discomfort or shame when asking for help so long after treatment. Again, this is really, really hard for me because I like to consider myself to be a strong person. So I'm not one that would be likely to ask for help. And then just being mad. Why do I have to go through this? Why me? Other emotions, relief that it's finally over, the cautious optimism. Every time around my mammogram every year, it's due in March, I find myself like getting really crabby the week before and emotional. Then I realize it's mammogram time. So those are normal things. And then concerns about chronic health problems. Once you've had cancer, I have a cough and I think I've got lung mets. I have a pain in my right upper outer quadrant. Couldn't be my gallbladder. No, I got liver meds, So this is constant concern, constant. And the fear of recurrence can interfere with every aspect of your life, can be triggered by reminders, and can be masked by the effects of treatment. Next slide. So something I have to tell myself is when treatment ends, the warrior and his or her family often are not prepared for the fact that recovery does take time. In general, your recovery will take much longer than your treatment did. People often say that they did not realize how much time they needed to recover. And I can tell you, even almost 5 years out, I still feel that I'm recovering, maybe the rest of my life. Next slide. Learning and teaching points is realization that the breast cancer survivor and patient may have different emotional needs and physical needs. And the effectiveness of good communication skills is critical, and the importance of information. Remember I talked about before, if I work in the field and I didn't know, can you imagine the people that, I can't even tell you how many times, I have friends of friends calling me. All they want is information. And also to realize that having cancer is a loss. And this is from a book on grieving and grief. And we do experience these: denial, anger, bargaining, depression, and acceptance. Important communication tips for text. Speak a patient's language. They don't even know a lot of times, you guys, right? When they tell you they've had a lumpectomy, but then you ask them what type of treatment they had for their cancer, and they say, I didn't have breast cancer. So make sure they understand what you're talking about. Use language they understand. Do not offer opinions or share your personal cancer experience if you've had one, because you guys know there's so many different options that are available to each and every person depending on their circumstances. One person may not have the option for having a lumpectomy. Somebody that may have the option of having a lumpectomy may choose to have a mastectomy. We can't judge, okay? And when we're addressing the patient, always being respectful. And, I'm a hugger by nature, but I think we have to be respectful. And I always ask a patient, can I give you a hug? And you can kind of tell when to do it or not. But, that's for breast cancer survivors. A lot of times we need a hug. That's super important. What not to say to a cancer patient: what are your odds? Don't ask, okay? Or I had actually, somebody told me, you work too hard, you're too stressed out, you brought this on yourself. This is a mammographer who said this to me. A horrible thing to say. Or I know someone with triple negative breast cancer and they died. Oh my God, what an awful thing to say. Or good luck on your journey. That's the person you guys should go on and look at this at Hutch News. You can Google this. The person who wrote it really has a cute sense of humor, and she goes, listen, I'm not going on a cruise to Acapulco. This is not a journey. So with that, just consider that. Or forget what your doctor says. Try X, Y, and Z. no, or saying nothing. So many times people say, I don't know what to say. Say, just call up. What I say is, if you don't know what to say, call up and say, I'm thinking about you and I really don't know what to say. How can I help? Don't do nothing, okay? Speak from the heart. Say, I'm so sorry you're having to go through this. Acknowledge the patient's feelings. Boy, this must be really scary. And respect their decisions. You know, I remember before my breast cancer diagnosis, I would sit with all the other mammotechs and, boy, if I ever had breast cancer, chuck them both off. And well, that wasn't my decision. And I think you can't judge until you're in that same position or in your own unique position. Use this new knowledge to create compassion for your patients. And the importance of education, to learn all you can, to ask questions, to read, and to understand the patient's experience, and use the information to be compassionate toward those who are trying to find their way through the breast cancer experience. And this is why I'm sharing mine with you. Because remember, knowledge is power. What can you do as a friend? Next slide, I'm sorry. Speak from the heart. Help with specific tasks before they're asked. My neighbor came and mowed my lawn every week. I never asked. And that was so helpful. Because remember, I hate to ask. So just do stuff. I had people drop off soup on the front porch. You know, that meant so much to me. Remember, even cancer patients can get cancered out, especially those of us who work in the field. Be there and have compassion. Next slide. Remember, cancer bring changes that are not always for the worst, and they bring about healthy personal growth. The cancer experience and your emotional responses can become important resources as you face the future. And I think we heard those stories over and over today. Next slide. Compassion is the most important thing that we can give to our fellow human beings. Next slide. And hope. Next slide. And remember, every time you're doing a mammogram, you are giving the patient the opportunity of having hope for survivorship, okay? You are literally holding their lives in your hands. Next slide. And finally, I want you to remember, this is personal. Each and every patient belongs to someone. Take the time to see them as such. Next slide. This is my beloved niece, Sally, and here she is wearing the wig that cost as much as a car, just saying, that she sent to me after she was diagnosed with breast cancer and lost all her hair. Now, almost 15 years later, she has two beautiful children, beautiful young children, as you can see here. So she's doing well. And here is my sister, Joan, who was diagnosed with a small invasive breast cancer 4 months after I was. I mean, talk about my poor mom, 2 daughters with breast cancer, but all of us are doing well. One of my favorite quotes is, the real voyage of discovery consists not in seeking new landscapes, but in having new eyes. I hope you'll remember this as we all move forward in our growth as healthcare providers and as women. You know, the reason I like this quote is because I always try to look for something that I can learn from a situation. And when I first looked at my ultrasound of my breast cancer, I just looked at this. I rolled over and I looked, cranked my head and I looked and I went, oh my God, this is not good. So what I want you to think is that we can have new eyes. Look what I see now. Can you see it?
Yep.
It's the pink ribbon, the symbol of hope. Next slide. Thank you again for your time and attention. Next slide. Please join our Quality Breast Imagers Facebook group. We have over 6,500 members from around the world, and we post cases and support. and would love to have you guys as members. I also wanted, next slide, to let you know that we're going to be doing a live conference in Toronto on the 29th and 30th of April. So if you want to come and have some hands-on experience, that's your chance. And next slide, you can contact me anytime at Louise at Mammography Educators, and more information about all our programs at mammographyeducators.com.
Fantastic. Louise, thank you so much for taking the time to spend with us today. And what a great, great event you have just made for us. Thank you.
Oh,
it was fantastic to hear about your journey. And we were all thinking about you when you were going through all of this.
I know you were, and I felt the love, honestly. You know, these Canadian technologists and just people in general are so close to my heart. I always love coming and working with you all. So thanks for your support and your love, and I feel it.
So I don't believe there's any questions for Louise, is there? No questions. So thank you once again, Louise, and I'll be in touch with you, and my thoughts are with you.
Oh, thanks, and have a great holiday, you all.
Thank you. And we do have a question for Dr. Feinberg. So if Dr. Feinberg could come back on.
Okay, so this question is for Dr. Feinberg. It says, as I understand it, tomosynthesis screening mammography is currently offered in some provinces in Canada. When can we expect tomosynthesis to be part of the OBSP screening protocol?
Okay, thank you for asking that question. Currently, the OBSP, it's not part of like the screening protocol, but it's recognized as a diagnostic study. We know some sites are doing it at screening, so technically, and this isn't exactly how we practice, but technically you would enter in the results of the mammogram, the 2D mammogram, as the screening study, and the tomosynthesis would be considered like a post-screen diagnostic study. So currently there is Ontario Health Assessment, like Technology Committee, OTAC. They are doing like a review of supplemental screening, and hopefully we'll get the results soon. But as of now, it's not part of the screening protocol.
Great, thank you very much, Dr. Feinberg. So, okay, the next slide, it just talks about the survey for you to get your certificates. Because we have had some access issues through Q&A, the link is actually in the Q&A right now for you to get your certificate, and without that link, you won't be able to get it. So we do monitor who is on this call and all the emails that have come through. So whatever email you have signed in with today, I will be sending the link out to you as well. But you're more than welcome to go ahead and go through the Q&A to get this and send it, send your answers, and we will get your certificate to you as soon as possible. So that concludes our event for this year. Thank you so much on behalf of the Central East Regional Cancer Screening Program. A great big thank you to all of you for all your wonderful work, and to all our wonderful speakers today. And I hope that you've all enjoyed it and that you will come back again next year. Stay safe. And let's just leave this open for